Dr. Noor,
Yeah.
you did not assign co-host today?
Whom? Dr. Zeva is co-host now. Dr. Matsuka, you are also co-host, I think. Just hold on, Shaista. Yeah, you have one device. You are a co-host.
Okay.
I'm just making the other as well. So you are host in both the devices.
Yeah, actually, my internet is very unstable. So I don't know which one will work when I will present. Thank you.
A very good morning to everyone, and a heartily welcome to all the participants on the last day of GIAN series on orofacial pain. Three lectures are today. First is by Professor Matsuka sir on the topic evidence-based learning. Second lecture will be delivered by Dr. Shaista ma'am on the topic translational research in understanding pain mechanism. And third lecture will be delivered by Professor Matsuka sir on chemical transmitters and non-neural mechanism in pain control. And after that, platform will be open for question answer session. Now, over to you, sir. I would like to invite Professor Matsuka sir.
Thank you, Dr. Jiba.
Thank you, sir.
I will present today's session. Oops, sorry. I will start the slides. All right. So, can you see my slides? Yep.
Yes, sir.
Thank you. So, in this session, I will talk about how to conduct research to learn orofacial pain mechanisms. Here is the ski resort area. You can see the beautiful picture. Tokushima is the south part of Japan, the warm city, but we have some snow, so in Tokushima, we have the snow ski resort area. I haven't been there. All right, so we can learn the pain mechanisms or new treatment methods from previous reports. However, we don't know whether the reports are true or not, because people easily tell a lie, even though they do not want. So we should know how to conduct research. Also, it is interesting to find basic pain mechanisms. So when you do or we do research, we should realize that there are many pitfalls around us. So common pitfalls in the research process. There are 5 pitfalls of the research, they said. So the 5 phases. So planning phase, data collection analysis phase, writing phase, journal submission phase, and rejection or revision or acceptance phase. So in each phase, there are pitfalls. One of the common pitfalls is occurred in data collection phase. So because the, so here I will tell you later about, we will test how much the pressure, we check the pressure, how much the rat will reflect that the stimulation. So if you know which side is painful, you can manage the data, right? So even though you don't want to manage data, maybe your hands can do that. So that we need to think about the many pitfalls. And so I don't tell you the more pitfalls in this session. So you can learn regarding the pitfalls. So I will tell you the basic steps in the research process. Step 1, identify and defining the research problem. Review the literature, get background information. Step 3, formulating a hypothesis. Step 4, research design. Step 5, carry out the research process. Step 6, preparing research results. And step 7, reporting research findings. That is the basic steps. So we need to follow these steps 1 to 7. Then we can write a paper and publish a paper. So first, we need to find interesting topics. It is important that you or we will select an interesting and important topic for us. Interesting topic may, how can we find? We can find from clinical experience. Also, we can find from reading books. Also, we can find from review papers that already they published. It's okay. So regarding the clinical experience, you can have the question, many questions, right? So one of them are, does NSAIDs decrease muscle pain? It's a good question, huh? And also, does sleep deficiency induce chronic pain? Also good questions. So you can have if you have these questions, you need to think, how can we know the answer of these questions? So you can read the books also to find the interesting topic. When I type in the Google Orofacial Pain book, we have got tons of books we can find, and you can read any books, and you can find the interesting topic from the books also. Also, in PubMed, of course, you know PubMed, right? You can type PubMed in Google, you can find this search engine, and we can check the previous papers. And when you check the review and systematic review, and when you type the orofacial pain and the mechanisms, you can see these review papers, and you can read these review papers. And in the review papers, they wrote what the limitation of the current orofacial pain mechanisms. Also, that they wrote what we need to do in the future. Okay, so find the interesting topics for the research. Some books and research reviews reported the future direction that we need to go, and also that they wrote the facts that we need to make clear. So we can find the interesting topics from these future directions or facts that we need to make clear. So from these books or review papers, you can find the interesting topics. So after you will find the interesting topic, you need to decide these things for orofacial pain mechanisms. Target places, target mechanisms, target molecules, methods. Regarding target places, you can check peripheral site or sensory ganglia or central site or brain. You can decide which which place is your target. Also the target mechanisms, you can select the signal transduction, or you can also select the receptors or channels. Also target molecules, you can select which molecules you want to know. Also methods, there are several methods, basic science, basic research, or clinical research. Also you can select if you will select the basic research, animal study, you can select the type of pain model. Okay, so if after selecting these after decide your research plan, you can search the paper also. You need to know the previous, you need to find what previous paper said. And here I typed orofacial pain mechanisms, but you can type more detailed questions, trigeminal ganglia or sodium channel or something. You can search more detail. Then you will find the previous research, and then you will find what you will do. All right, so decide the research details. We should decide the research details, target places, target mechanisms, target molecules, and methods for finding the orofacial pain mechanisms. Yes. So target places, there are many target places for the orofacial pain mechanism: receptors, peripheral site, and primary afferent, axoplasmic flow, the nerve flow, and also the sensory ganglia, spinal cord, tract from spinal cord to brain, and also target in the brainstem, and then diencephalon, thalamus, telencephalon, cerebral cortex. Also, you can target the autonomic nervous system. So here the picture. So if we have the nociception in the peripheral site, so peripheral receptors are one of the targets, of course. Also primary afferent, axoplasmic flow is also target. Also trigeminal ganglia should be target, and in the spinal cord, and the tract, here tract, and the brainstem. So also the autonomic nervous system is one of the top target place. So these target places depend on your clinical question or research question. So you will decide the research question at first, then you will check you will decide which target place is the best for your research. So let's say peripheral, if you want to know the peripheral transmission, I showed you before this picture, the peripheral transmission, macrophage release the cytokines, and also mast cells release the histamine, bradykinin, prostaglandin E2, or tissue damage release adenosine, proton, or ATP, and also immune cells here. And these release molecules go to the bind to the receptors, and the substance P and CGRP is released from the nerve ending. So also the tissue damage induce the macrophage, mast cell, T cell, neutrophil release some molecules and bind to these kind of the G-protein couple or kinase linked receptors. Also ion channel receptor is induce the calcium or sodium influx. And also heat or chemical stimulation also induce the calcium influx and depolarization and nerve excitation is there. Also, substance CGRP release and vasodilation, extravasation occurred. So, question: how? So, if you can have this kind of question also, how does macrophage release NGF, nerve growth factor? How? So, macrophage, you need to think about. So maybe you will get a macrophage at with some procedure, only macrophage, you will get only macrophage on the dish. Then you will add something and you will check the NGF is increased or not. That is one of the protocol. So, so if you will have the questions and also the theory, you will think about the method also. So is the NGF release increased in pain model? How can you do that? So you will make the pain model and the normal model and check the macrophage releasing the NGF. You can compare with some method. So that is a so one of the research plans like this. And also the peripheral transmission, again, in this, if we have the tissue damage, bradykinin or serotonin or prostaglandin or ATP and proton binds to the nerve endings like this, right, with right side. Then from nerve ending substance P or CGRP released and go to the mast cells, our neutrophils, and mast cells and neutrophils release a histamine. And also the depolarization goes through the dorsal ganglia, trigeminal ganglia, and go to the central nervous system. So this right side is the same. The mast cell release the serotonin, histamine, prostaglandin to bradykinin. Macrophage also release the bradykinin, IL-1 beta, sodium, not sodium, nerve growth factor. Also some kind of the cytokines. And tissue damage induced adenosine or ATP or proton. Then they bind to this kind of the receptor and go to the action potential in the nerve. And also gene regulation will have occurred. All right. So other question is, how does bradykinin bind to the receptors? How does bradykinin release from macrophage or mast cells and bind to the B2, B1 receptor? How? Can you think about how? So you need to read the previous papers, and also you can find mechanisms. Also, you can find how to how to do the research also. Does it induce action potential also? So how can you check the action potential? Electrophysiological recording, you can do that. Yeah, so you need to think about methods also and the result also. You can think about the result also. All right, so regarding the sensory ganglia, if you have the target, if your target is sensory ganglia, let's say sensory ganglia abnormal firing was reported in neuropathic pain model, and so maybe in sensory ganglia there are neurotransmitter release in the sensory ganglia and affect to the pain as transmission. So here in sensory ganglia, there is a neuron, and around the neuron there is a satellite glia cells, also macrophage there. So the other question is, how does satellite glia cell communicate to the trigeminal ganglion neuron? How? So you will check what is released from neuron, and also you can check what is released from satellite glia cells and affect and give the neuron or satellite glia cell these kind of molecules, and what happened you can check. That is the one way. Also, there are several ways to check these questions, answer these questions. Okay, so pain transmission in sensory ganglia. The interaction between the sensory neurons and the glia cells, there is hypothetical interpretation of the interaction between the neuron and glia cells in the sensory ganglion due to chemical transmission. So actually, my name is here, but the Dr. Shyster draw these figures. So here's a neuronal cells, also the satellite glia cells in the sensory ganglia, trigeminal ganglia. And from the satellite glia cells, if after calcium influx, BDNF, CCL21, or the other cytokines released, and also these released cytokines go to the neuronal cells probably. And after the excitation, neuronal excitation, ATP or substance P, CGRP or GABA are released. And then ATP may bind to the satellite glia cells receptors. So if you want to know does satellite glia cells release cytokines? How you can do that? Does satellite glia cells release these cytokines? If you want to know, so you will get the only satellite glia cells on the dish and put the stimulation, and you can check the cytokines in the dish. If in vitro study is okay. If you want to do the in vivo study in the animal body, story is different. You can have more challenging research. Okay, so other pain transmission sensory ganglia study. So again, in sensory ganglia, there are neurons, and also around neurons, satellite glia is here, and information or pain goes to the spinal cord. And also there is a neuron and the neuron communication. So one neuron is depolarized, go to release a substance P or ATP and activate the other neuron and depolarize the other neurons. There are different studies showed, Takeda et al. Showed, and also neuron satellite glia cells relation also Takeda reported. So this is a satellite glia cells, this is neuron. So after satellite glia activation, cytokines released, IL-1 beta, TNF are released and bind to the neuronal cells, and neuron cells also excited, and the ATP substance CGRP released and binds to the receptor on the satellite glia cells. He wrote. So we can have these kind of questions. Substance P activate the neuron and induce depolarization. Substance P binds to the neuron. So substance P activate a neuron and induce the depolarization. How can you check? It's tough, but it's interesting, right? I hope you are interested in. But so substance P. How can you check the substance P activated neuron? Maybe you will get a neuron on each dish and add the substance P and check the action potential or some kind neuronal recording. And then you can say that, oh, maybe the substance P activate the neurons. All right, it's okay. So regarding the central pathway, primary afferent fibers, A beta, A delta, and C fiber transmit impulses from the periphery here. A beta, A delta, C fiber transmit the impulse from the sensory periphery through the dorsal root ganglion, or trigeminal ganglia also same, and into the dorsal horn, the spinal cord. Nociceptive specific cells are mainly found in the superficial dorsal horn, lamina 1, 2. So these kind of C or A delta fibers go to the lamina 1, the surface area of the spinal cord. And whereas most wide dynamic ranges are located deeper, lamina 5. So touch sensation or the other sensations also go to the deep area. So there are some reports here, right? So can you imagine how the researchers found? Can you imagine? So how could they find these pain sensation go to the lamina 1 or 2? How did they find these touch sensation go to the deep area? It's tough, right? But they did. So of course you could do it. You can do it. So if you want, you can check these kind of the things, and also you can find more new novel things. All right, transmit with spinal cord mechanisms. Several cellular and molecular mechanisms involved in the spinal cord and responsible for the development of chronic pain states are described in the following sections. All right, so here the delta and C fiber, so pain fibers, and the NGF induce the BDNF substance species CGRP release or glutamate release, and these kind of the neurotransmitters bind to the postsynaptic and induce the chronic pain. Also, around these kind of synapse, we have the inhibitory interneurons, and also the astrocytes, microglia. Microglia has an ATP receptor, and cytokine is released from microglia. Also, descending tract is here, and norepinephrine, opioids, and serotonin. And also the presynaptic area or postsynaptic area, some receptors here. So already some from previous research we know. So what next question is does microglia have ATP receptor? How can we find microglia has ATP receptor? So maybe we can check the slides and stain the microglia and the ATP receptor, and you can check the co-localization. What happens after ATP binds to the microglia? Microglia doesn't have the action potential. So if ATP binds to the microglia, what happens? It's an interesting question also. And also what will you do? What will you for the research? It's also good, interesting questions. All right. Regarding pain transmission with spinal cord mechanisms, structural changes increase the release of excitatory substances, functional changes in receptors and ion channels, disinhibition, glia activation, and release of chemokines and inflammatory substances may contribute to the pathological changes involved in pain following injury. So again, I told you this story. Then one place of the spinal cord is activated. So my question was is that after one place, right? One section in the spinal cord is activated. What happens in the other places? So of course, there is activation here. So the other place is also activated or just silent? Or why? Is a good many questions. There are many questions for me. All right. Also, the pain transmission in the brain. Key brain regions related to somatosensory blue color, affective green color, and cognitive orange color for pain processing. Only regions of interest have been included for clarified there. So somebody reported already. So question that does pain sensation induce cognitive change? And what is the mechanisms? What is the basic mechanisms? So again, you have many questions. You can have many questions, and most of them is not clear so far. So you should consider the basic science research or clinical research. And also pain transmission in the brain. Somebody reported the functional MRI, and they found which part the brain is activated in the stimulation or in the pain. So there are several research like so you can also do the clinical research, and you can do the function MRI or the other imaging system for checking the pain transmission. All right, so finish the places. So move to the target molecules for pain transmission. So there are several or many molecules. So you can try any molecules. I will just introduce algogenic substance, potassium, histamine, serotonin, ATP, or inflammatory mediator, prostaglandin, serotonin, cytokine. Neurotransmitters, glutamate and glutamine, GABA, noradrenaline, substance P, or ATP. ATP also neurotransmitters. Endogenous opioid peptide, morphine, cannabinoids, cannabis. You know cannabis, yeah? Marijuana, right? And enzyme, cyclooxygenase, nitric oxide synthase, protein, gene, oncogene, neurotrophin, nerve growth factor, brain-derived neurotrophic factor, BDNF, fibroblast growth factor, epidermal growth factor, hormone, corticotropin-relating hormone, melatonin, lipid, phospholipid, and also vitamin B, etc., etc. So signal transduction is also the molecules, target molecules, NF-kappa B, FGF, Wnt signal, Notch signal. So there are many target molecules for the pain transmission. And also the target mechanism for pain transmission. So you can check the mechanism, receptors, G protein coupled receptors, channels, voltage-dependent channels or ligand-gated ion channels, transporter, vesicular transporter, plasma membrane transporter, also cytoskeleton, cellular adhesive molecules, extracellular matrix, and signal transduction. So there are many target mechanisms also. So question, is cytokine related to orofacial pain sensory ganglia? And I typed the orofacial pain and sensory ganglia and cytokine. Today I checked, the results are different, but previous day, several months, actually months or 1 month, I think 1 month back, when typed this one, the first one is the role of chemical transmitter neuron glia's interaction and pain in sensory ganglia. Dr. Shaista is here. So that is Professor Shaista's research. CGRP and or minocycline were administered directly inside the trigeminal ganglia. That's why evaluated for thermal hyperalgesia using an operant orofacial pain assessment device at 3 temperatures. And PCR was performed, and cytokine antibody cytokine array was performed. CGRP caused the hyperalgesia. Messenger RNA and protein expression of GFAP was increased in parallel with an increase in messenger RNA expression of inflammatory cytokines. Minocycline reversed CGRP-induced thermal nociception, glial activity, and downregulated L1 beta and IL-6 cytokine significantly at 6 hours, she found. All right, so Dr. Shaista will tell the translation research, right? So there are several types of research: basic research, clinical research, and between the basic and clinical research, there is a translation research. Basic research, we can know how does nature work, what causes the disease. Clinical research, are these treatment strategies safe and effective in humans? And translational research, how can biological knowledge be used to treat disease? So basic research is curiosity-driven and asks fundamental questions: how, what, why, about the core building blocks of life. The purpose of basic research is to understand how nature works. And also the clinical research takes the success of translation research and tests whether they are safe and effective in treating disease in human clinical trials. Translation research is more focused and applies information from basic research to ask how scientists can use this knowledge to improve human health. It takes basic facts of how life works and translates from them for use in potential therapeutics. So animal model for orofacial pain. Researchers must consider the significance and importance of their research. The number of animals to be sacrificed should be minimized. We shouldn't kill many animals. The pain to the animals should be minimized, yes. So I thought about, so for the animal model for orofacial pain, acute pain, neuropathic pain, inflammatory pain, arthritis, muscle pain, bone metastasis, and postoperative pain, stress model we can have. So these are the pictures. So acute pain, we can give the mouse or rat model, the pulpitis. Also, we can put the artificial crown on the tooth. Then it's this rat or animals has acute pain. Also, the neuropathic pain, trigeminal neuralgia is infraorbital nerves here. And then we constrict or cut the nerves. Facial neuralgia, there are the facial nerves, so we can cut or pinch or constrict the nerves. It's painful, of course. Inflammatory pain. So we can inject the irritants, inflammatory substance, and then we can check the behavior. Also, if you want to have the periodontal inflammation, you can put some kind of the threads or some kind of the device for the implantation, and we can induce the inflammation. So muscle pain, we can do we can give the exercise to animals, or immobilization. Don't move. Immobilization induces the muscle pain also. Also, reserpine injection induces the muscle pain. But the reserpine model is a kind of the I forgot. Actually, reserpine induced the muscle pain model. Also, bone metastasis pain, we can inject the breast cancer cells. Then breast cancer cells induce the bone cancer, or the tongue cancer also. We can, if you inject tongue, you can make the tongue cancer. Also, stress model, we can put the wet bed, or you can put the rat on the water. It's a very stressful. Also, the electric shock, rat had or animal had a lot of stress with this. Okay, so methods. So you can decide target molecule and target place and the pain model. And you can know how you can test the animal pain. So Fonfrey test is a method evaluating mechanical rhodynia in mice and rats, or also the other human also. Mechanical stimuli were applied to the whisker pad using the Fonfrey filaments to measure mechanical head withdrawal threshold. So we can measure the head of withdrawal threshold. How many grams induce the rat or mouse reflection. Also, the methods, the rats were evaluated for thermal hyperalgesia at 6 and 24 hours post-injection using an operant orofacial pain assessment device at 3 temperatures. So this pipe is hot. This is a new one. This is the old one, and so this pipe is hot. So if you put the hot pipe, and rat is drinking the milk, through the with touching by touching the pipe. So the hot pipe is hot, so it's become painful. So that moves out from the pipe. So rat is drinking the milk. So it's very painful, sometimes very painful. So rat moves back sometimes. Can you see? Not yet. Go. Yeah, see, you see the rat moved back. This is a normal rat. So he could continuously touch the pipe. All right. So the other method is actually Dr. Shaista inject the CGRP along aminocycline with CGRP to the trigeminal ganglia because we want to know the mechanism of the trigeminal ganglia. So she injected the drugs directly into the trigeminal ganglia. And she found this paper. And previously, we found, you should search the papers. And she found that the Newbold et al. Did the same question, had the same question, did the same way. So she, through the infravitreal foramen, we insert the needle through the foramen and then inject directly into the trigeminal ganglia. Also, the quantitative methods, PCR, quantitative real-time PCR was performed to evaluate messenger RNA expression, IL-1 beta, IL-60, NF-alpha, IL-1 receptor antagonist, sodium channel 1.7, and glial fibrillary acid protein. So we can check the messenger RNA. Also, this is the Dr. Shaista's research she used. Also, she used the cytokine array. The cytokines released in culture media from purified glia cells were evaluated using the antibody cytokine array. So we check the which one is the more cytokine or cytokine volume, cytokine, how much cytokines in the fluid. Cytokine is an antibody pair-based assay analogous to ELISA, but using a membrane as a substrate rather than the plate. It's okay. Also, we need to know the statistical analysis. Of course, statistics important. There are several tests, paired test or ANOVA or some the other test. So you need to know that if when you do the experiment, you need to know the statistics. Best thing is consult statistician before starting the experiment, not after the experiment. Before the experiment, you should contact the statistician. All right, so after this experiment method, you can have the results, right? Of course. Then you will have the good results and you will discuss the results and you can write manuscripts. And also you need to discuss with the colleagues regarding the manuscripts. All right, that's it. Thank you. Dr. Ziba. Do you have questions? No question, huh?
Thank you, sir, for your enlightening lecture. Now, I request all the participants to come with their valuable questions.
Hello, sir.
Yes.
Sir, I have a question. Sir, you asked a research problem that does ATP bind to microglia cells? Sir, in one of the slides. Sir, how will we decide that which pain model will be used to do this research, sir, if we want to?
Microglia.
Yes.
Are you doing the experiment? Oh,
So you raised the research problem, sir,
research
that
problem.
does ATP, yes, sir. So does ATP bind to microglia cells? So you raised this research problem. Sir, then how will we decide that which pain model can be used to like research this?
We can decide, actually you can decide, or we can decide any models. So if your target disease is a neuropathic pain, you can use a neuropathic pain model. If your target is inflammatory pain or periodontal disease, you can modify these models. So depend on your research questions, you can decide the model of the pain model. Did I answer your question?
Yes, sir. Thank you, sir.
Thank you.
There's a question in the chat box.
Oh. Good question. How do you think, Dr. Shaista?
I think latest operant orofacial pain assessment devices are the best until now.
Oh yeah, everybody says like that. So as there are several types the record. So I cannot say it's best, but as Dr. Shaista said, heat stimulation is drinking and touching the heat pipe is somebody said, as Dr. Shaista, somebody says it's a good way to check the pain. But the one phrase also, I think it's okay. But depend on the research plan, you need to change sometimes because if you want to know the difference between right and left, you cannot do the operant assay. The drinking milk is that we cannot differentiate right and left pain. It's okay. Thank you.
Hello.
Yes.
I would like to know how many animals we should use minimum. Minimum how many animals we should use to experiment to conclude a study.
Good questions. So depend on the experiment. If you have the much difference, you don't need to use many animals, right? That's 3 or 4 animals, okay. But if the difference is very small, you need to use 10 or 11 animals. So I can say you can do several mouse, 3 or 4 rats or mice experiment at first. Then you can check the data. Then you can you can calculate the power. You can calculate with the power analysis how many samples you need. Then you can, if you want to show the difference, you can do that. You can increase the number of the animals.
Can we use only one animal to check the feasibility of the experiment, or just like a pilot study?
Yeah, of course you can do that. But yes, you can. But if we want to calculate the power analysis, you need to have some.
Okay.
Hello.
Yes.
I have another question regarding animals. Which animal you feel is good to work with for pain model or for oral research, you can say?
So usually people use the rat or mouse. Sorry, rat or mouse. So I think rat or mouse is easy to use, and also if you want to have the genetic model, mouse is the best. So, but mouse is for orofacial pain model too small. Sometimes difficult to have the neuropathic pain model with mouse. So, I usually use the rat.
Okay. Thank you.
Thank you.
Any more questions from the participants?
Sir, I have a question.
Yes.
Sir, if due to any ethical reasons we are not able to conduct an experiment on animal models, is there any other model like cell line model on which we can conduct this kind of experiments?
Yeah, you can do that. So you can do the cell line models, also good. But you need to think about what you can do with the cell line, because cell line didn't say it's painful, right? So you need to get the previous data, and you need to find that methods with cell lines. So, but you can do the cell line, the research with cell lines.
Any more questions from the participant side? I think no more questions. Now I think we should continue with the lecture of Professor Shaista ma'am on the topic translational research in understanding pain mechanism. Over to you, ma'am. Yes, ma'am. Ma'am, turn on your microphone.
So, good morning, everyone. Thank you, Zeba, and thank you, Professor Matsuka, for such an enlightening talk. So, I learned all the basic science research in his lab, so I cannot say that what I'm going to say will be better than him. So, he talked a lot about the target. So my topic is translational research. So I'll be talking about, again, the target. So what are the target? What he meant by target? So identifying a new target. The target is actually, because we are talking about pain translation. So our target is to find a new chemical which can bind to a target. That target is druggable target. That can be, that target can be attacked by a drug, and so that it can modify, that drug should be able to modify the target to achieve an outcome, the final result. That means in this case, if we say we are checking, because most of the time, right now we are discussing about the pain. So I'll be talking mostly about the analgesics and other biomarkers which can modify the target in such a way that either we are able to understand the pain mechanism, or we are able to alleviate the pain. So this journey starts from basic science research. That means in the hood with a lot of cells, and this is very extensive. It needs a lot of extensive research, and a lot of time is needed. Like sometimes 10 to 15 years are needed for translation from basic science to the final outcome, like final discovery of a molecule that is good enough to be used in human models, as well as expensive because it involves a lot of money. It's not easy, and not everybody can afford to do research, I should say. So it starts with basic science research, and then next step is preclinical research, which involves preclinical animal models to ensure the mechanism of action of what we learn in the lab in the cells. We wanted to ensure that the same mechanism are occurring within the animal models or not. And then we also check if the drug is safe. It doesn't have any toxic reactions or allergic reactions, its efficacy profile, and its potential toxicity. And then next next step comes the clinical trials in humans. So all these, this journey from basic science research to clinical trials is a very long journey, though it is expressed in only one slide. So now, what is translation? If we, the definition says that multi-step process of turning observations in the lab, clinic, and community into interventions that improve people's life in the form of diagnostic. So after translational research, we have better diagnostic tools, better therapeutics. We should have ideally better medical procedures, better medical devices, like a better ability to treat patients, and behavioral changes which are conducive to good health. So this is what translation is. Now, there are various phases. Like Professor Matsuka described about the preclinical animal study that comes as the bottom line, or from where any research starts. The research doesn't jump to the last stage, that is T4, translation to the community, starts from the bottom. And then it proceeds from translations to human most of the time. First human study is done on healthy subjects, very less number of healthy subjects. And that kind of study is called as proof of mechanism of proof of concept study, that is phase 1 clinical trial. And then next come translation to patients. So less number of patients who have that predetermined disease condition, and in those patients that drug is tried, which was tested and approved in the previous phases. And then phase 4, where clinical trials and clinical outcome research is delivered to more number of patients to see more effect. And then finally, if it passes all the tests in the line, it reaches the community for the true benefit of the society. So it's a long process, long journey. So right now I will talk, because it's a long journey, so it cannot be explained in one small lecture. So today I will talk only about the proof of concept and proof of mechanism clinical trials, which are early phase clinical trials. Okay. So the first step in testing a new treatment in humans is phase 1 clinical trial, which tests the safety, side effects, best dose, and timing of a new treatment. It may also test the best way to give a new treatment. For example, like the delivery route for a drug. For example, you want to give intravenous or intramuscular or mouth or infusion, whatever. So that is what is decided in the preclinical stage trials. And then dose is, starting dose is small, then it is stepped up until we reach a level which is highest tolerable level, and which does not have any harmful effect in the subjects we have chosen for phase 1 trial. So these trials are called as phase 1 trials. Now, what are the challenges from bench to bedside? So it's not easy. Sometimes it is not easy because when we are translating, we are depending, it's not like I am basic science research and I will translate my own research. So there are basic science researchers, there are clinical researchers, and there are preclinical researchers. So every level has to depend on its previous level to depend on their results. So if their results are flawed, if there was some problem in their experiment, and if their reporting was flawed, so of course, the amount of error will multiply at each level. So a flawed preclinical information can be we cannot say from the results whether the preclinical design was flawed or not. Second thing is, poor clinical study design itself may generate bad results. And now it is the researcher who is performing the research. It's his responsibility to check that clinical study design is flawless and meets the standard laid down by various agencies of performing those researches. And again, as Professor Matsuka said, read a lot of papers, a lot of articles, a lot of literature, which is nowadays it's easy to get access to this literature. Now, the other challenge, which is a very big challenge, is the difference between human biology and animals. So until this date, there is no animal which is a perfect replica of human biology. So whatever animals we use, like just now he said, for neuroscience research, most commonly we use rats, because their nervous system is similar to, not similar to, but somewhat, some of the properties are parallel to human being, but still not exact replica. So there are differences at all the levels, from peripheral nervous system to autonomic to central nervous system. So this is again a big challenge for translation. Next is the pain assessment tools which are used in animal model, like the one which Professor Matsuka showed just now, one Frey test or thermal stimulation test. So these tests actually check the responses at the spinal level. So this is a big difference between human beings, because day before yesterday in my lecture, I told you the different measurement method of pain, and we discussed that most of the pain methods are subjective. So in human beings, what we are recording as a pain is most of the time self-reporting, and that information is generated in the brain. So this is a big difference. In animals, we are getting spinal response, and from human beings, we are getting brain response. So it's very difficult to compare the two results. They are not comparable. Okay, and now there is lack of an objective marker. So I said pain is always most of the time subjective measurement, most of the time, though there are tools which are developed, which are being developed and which have been reported to have some objective property, but still a perfect tool is lacking. Some health assembly, I don't remember the exact name of that assembly, they declared that pain should be included as a fifth vital sign. What are the other vital signs? Temperature. So we have thermometer to measure the temperature. Respiratory rate, we can measure that. Blood pressure, we can measure that. And we can measure breathing rate. So everything, all the other vital signs can be measured accurately using some kind of measuring devices, but then pain cannot be measured. So though it has been included as a vital sign, but it still lacks the ability to be measured objectively. Now, there are other confounding factors also, which are challenges for converting a bench result into clinical research. So the comorbid conditions. So in human being, pain will never be like, even if there is one factor which is causing pain, there might be many comorbidities which are affecting or which are modulating the pain response. So gender, genetic difference, secondary gains, these are all the factors which can affect the results in human beings. But when we make an animal model, we have only one condition. So either we are making a neuropathic pain, or we are making an isolated diabetic neuropathic pain model, or isolated models are there. Those comorbid conditions are not present. Even if you try to replicate, you will create only one or two comorbidities, but you cannot have the complexities of a human body are not there. And then psychological factors, social factors, it's difficult to replicate everything. Then multiple cellular mechanisms are there which are acting. Just now Matsuka Sensei showed us several slides like ATP, cytokines, and then bradykinin. There are so many neurotransmitters, so many pathways which are occurring to cause only one pain. A neuropathic pain is separate pathway, and then multiple pathways are activated to generate some kind of translational changes. So it's difficult to have to understand. There are means to understand it at cellular level, but able to understand it in human studies is very difficult. And then multiple clinical phenotype, multiple cellular mechanism may be there in one person having pain, or multiple clinical phenotype may be present in one person. So it's very difficult to replicate through model. And then multidimensional feature, which includes all of the above I said just now. Now, one thing is that why do we need to have translational research in pain diseases? So until this date, there is no no satisfactory treatment. There are a lot of research going on related to analgesia. It's a big, huge market, huge R&D, but still there is a lack of 100% satisfactory one molecule which can treat all kind of pain. So that is refractoriness of pain to pharmacotherapy is again a challenge, which is faced by the researchers in this field. Now, what we do when we use a drug, whatever the chemical which is modifying the target, we always, our models have overt pain symptoms, either in animal or human beings. So they have like full pain. So the process is from etiology to syndrome. So this pathophysiology and this in-between stage is neglected. Always we work on the last symptom, that is our pain, neuropathic or chronic pain. So that is one problem with a lot of research which is being done. So lack of a diagnostic marker that occurs because there is a lack of diagnostic markers that allow the detection of pathophysiological or structural changes before the onset of overt symptoms. So what is going on before this is difficult to diagnose. So that is one another challenge when we are doing translational research related to pain medicine. Then there is lack of clinical and non-clinical experimental models that reflect the timing and progression of the disease. So this flow of events which is occurring in human body or an animal model is difficult to track. So that is again a challenge. So the next thing is that there is a lack of construct validity of preclinical models currently used during drug screening. The irreversibility of changes induced by signaling dysfunction and the absence of early diagnostic tools in humans lead to significant differences in treatment responses in animal and human. So there is a lack of biomarker which can truly tell us the progression of the pain, and which can and until the time we are able to diagnose, the most of those signaling pathway we talked about are in such an advanced stage that already irreversible changes had occurred. So those changes, as previously been discussed by Professor Matsuka, as nociplastic changes have already occurred, and it's difficult to track what happened in the past, because already we have reached a stage of irreversibility. So what can be the workable solution? It's difficult to find, right? So focus on the target. Treatment started before the overt symptoms are there. So again, it is out of our control. Prophylactic intervention, that is pathway engagement. Instead of engaging the target, we are engaging the pathway, we are controlling the pathway. So that can be one solution. Then identification of potentially new targets, like not working only on one target. Maybe there may be different targets which can give the similar results and which can help in engaging the pathway can be selected. So these are all the methods which we can try to sort out our problems. But again, it's all experiment, and we don't know if we are going to have success in the end or not. And then it takes a lot of efforts, a lot of time, a lot of energy to come to a conclusion. So for an analgesic to be successful and survive all phases of trial, so what are the factors which determine that this drug is finally should be accepted? So the things which we should consider in the preclinical, in the early clinical trial stages: exposure at the target site for a desired period, binding to the target for action, and expression of pharmacological activity. So these are the factors which we consider in the early clinical trials, that is phase 1 and phase 2. And then there is a quest to find a biomarker which can tell us about the exposure response relationship for progression from phase 1 to phase 2 clinical studies. So these are some workable solutions which we can think about when we are designing translational research. Now, today because I'm focusing on proof of mechanism and proof of concept, not on proof of principle. So I will talk only about that. So proof of mechanism studies are those studies which check the availability of the drug at the target site. For example, we are checking the model of osteoarthritis. So how do we know that the drug has reached its target site? So we will check the synovial fluid sample from the knee to check the availability of the drug in the fluid. So target engagement and intended pharmacological effect. So target engagement can be checked by various, there are various methods. For each drug, you have to design different target engagement methodology. So depending upon which receptor it is going to engage. So it is called as like a tailored made approach to prove the efficacy of the drug. For example, if we are talking about opioids. So we know that opioids most commonly engage the mu-opioid receptor, which are distributed all over the peripheral nervous system and all over the central nervous system. So to check if it has reached, engaged the target, most commonly people use pupillometry to check the meiosis of in the eyes. So that is one method. But there is again a question: is meiosis a peripheral phenomena or central nervous phenomena? So that question again put us in doubt whether the drug was able to reach the central nervous system. The effect which we see after the target engagement is because of the central nervous system involvement or peripheral nervous system involvement. Then these proof of mechanism studies are always done on small number of healthy volunteers. Next, it comes after proof of mechanism comes proof of concept. So these are done either on healthy volunteers or with a model which resembles pain condition that a drug is intended to treat, or a small group of patients which has the disease which we are intending to treat. So here we aim at dose selection, patient population to target, and then evade unnecessary. And this is important because we choose a small group of patients to check all what we have intended, and it avoids unnecessary investment in compound that otherwise were not fit for further use. Next stage is proof of principle, which relates to clinical development in phase 3. So that proves that the efficacy and the safety was significantly evident, and we can use it further. So early drug development is a role of proof. What is the role of proof of mechanism studies? So as I told, they demonstrate the target engagement, then biological response after target binding, and then effect of drug on cell biology based on the biomarker study is done. So what is being assessed is time to onset, like how much time the drug took to show its effect, duration of the response, for how long the response the drug was effective, and exposure response relationship, that is pharmacokinetics and pharmacodynamics of the drug is noted down. So it's an important tool for selection of appropriate dose for proof of concept studies. This pre-stage study is important for choosing the drug dose, which we will use in the next step, that is proof of concept studies. Now, what are the model requirements for proof of mechanism? So first thing is plausibility, that the model should activate the relevant mechanism of the target population. So we already know that this target we want to activate or we want to engage beforehand, and the model should be able to activate that relevant mechanism for which we are testing our drug for. Then translatability. The same model and same endpoint should exist for preclinical and clinical experiments. That means whatever we tested in the preclinical trials, so whatever we tested in the preclinical trials, so translatability should be there, then reproducibility should be there. That means the model should be highly reproducible within the subjects across several experiments. Like if we repeat the experiment 100 times, the result should be the same. Then robustness. like even if different investigators are performing in different laboratories all around the world, they are also able to get the similar results and similar endpoints. Validity, standard of care drugs should work in the model, and then dynamic range. The model should have a wide dynamic range to allow for pharmacokinetic and pharmacodynamic relation analysis. So these are some of the model requirements for proof of mechanism studies. For proof of concept study, when we design, it depends upon which pain model we are going to test, acute pain or chronic pain. So most commonly the clinical setting for acute pain drug analysis, we use in-hospital post-surgical settings. And most commonly models which are used for post-surgical settings are most commonly, there are 4 models which are given in the literature, and most common and most for acute pain analysis, the third molar extraction is the most popular and highly sensitive model which is used in the clinical setting. And for chronic patient analysis, we can do outpatient in a chronic pain clinic. For acute pain, surgical patient versus chronic pain, the same as above. And then duration of treatment for acute pain, it should be hours to days for our observation, and for chronic pain, it should be weeks to months. Now, research goals for proof of concept trials are, we want to check the safety and efficacy of new molecular entity, development and validation of new pain-related outcome measures, elucidation of physiologic pain mechanism, identification of biomarkers, and different mechanism of pain processing or analgesic treatment response. Our concept of mechanism-based pain treatment is the goal of proof of concept studies. Now, what are the various models which are used in these early stage clinical trials? So these experiment models are basically used to test the potential therapies. They should be reversible, or whatever the disease which we are causing, basically we are causing pain, should be reversible or transient. It should be an experiment in experimental induced pain. There should not be any long-term tissue damage or harm of the subject. Easy to perform and should bring about the reproducible results. So it's very hard to meet all these criteria, but it is very important from the point of ethics, because we are using healthy human subjects. We don't want to cause harm to them. There are reports in the literature where drugs were used in the clinical trials, early stage clinical trials, and it was found that they were not effective and they caused some kind of damage to the subjects on whom they were used. And then the companies have to withdraw the drug, or they had to terminate the trials. There is one very good example about the Bail trial. If you want, you can read it. So it's very nicely given in the Wikipedia. And then various models which are used to test the model efficacy in experimental human beings are brief thermal sensitization, burn injury, capsaicin application, transcranial magnetic stimulation, and cold pressor pain test. So nowadays, transcranial magnetic stimulation is getting more popular, but it is very expensive and needs big. We need to have functional MRI equipment in our setup to be able to do it. Now, this is one of the biomarker protocol which was published. Actually, it is a early clinical trial which is registered at clinical.org, and they published their protocol in this Pain Reports journal. They haven't published the results yet, but I like it because of the design of the study they used to check the cortical biomarker signature for predicting pain sensitivity. So they used a model, a human model for temporomandibular disorder to create a musculoskeletal pain. So here what they did was they injected nerve, it was part of their plan that they injected nerve growth factor, which causes kind of mechanosensitive effect when injected. So they injected nerve growth factor, and then they, for example, at day 0, before starting the trial, questionnaires related, which are given in the DCTMD, were selected and were asked from the normal subjects, and on that basis, the participants were recruited. Then pressure pain threshold, EEG, to record the peak alpha frequency, which according to them will be used as a novel biomarker for checking the pain chronicity of which patient is going to become a chronic patient in future. And then transcranial magnetic stimulation, and at the initial stage, then injection of nerve growth factor, followed by again these records. And then the subjects were supposed to maintain an electronic diaries or pain diaries for 0 to 30 days. And their endpoints primary outcome was that this nerve growth factor should be able to induce pain, transient pain, of course, not long-term pain. And then the biomarker which they wanted to test, like this pain should be similar, according to them, this pain has to be similar to the musculoskeletal pain in the TM because of in the myofascial pain dysfunction patient. And then this PPT, these values, pressure pain threshold should come down, EEG should show depression, and TMS should show peak alpha frequency, and corticomotor excitability should show changes after injection of these nerve growth factor. So I like this study because the protocol was very robust and was very nicely given. Each and every step was very described in extremely detail. So this was this study is being performed between two centers, between Maryland University and some in Australia. So the subjects model were created in Maryland University, whereas the statistical analysis was done in Australian Pain Research Centre, some in Sydney. So now, clinical models, we have to select clinical conditions to assess the preliminary signal of treatment efficacy. So we have to enroll the patients when we are using clinical models. Earlier, I said about human experimental models. So this is about clinical models, which I used to check the proof of concept trials. So here, those clinical conditions which are very specific and well defined should be selected, and there should be very well established diagnostic criteria to choose to select the patients. And then the disease should have enough prevalence, which we are checking. For example, diabetic peripheral neuropathy, post-herpetic neuralgia. So these patients we have ample number of patients to find and to decide which patient can enter the trial and which cannot. So significant patient heterogeneity due to multiple mechanisms can also be there in clinical models. Now, the research design for these kind of studies is parallel group. Like each participant is assigned one group. This is important when we are selecting selecting a drug which has long-term effect, and washout period from the body is very long. So parallel group research design is considered at that time. Next is crossover design. So every participant can receive more than one intervention. These kind of designs are selected when the drug washout time is less and the drug does not engage the target for a very long time. So this kind of trial can be used at that time. Enriched cohort trial is done when the increased likelihood that drug effect will be detected. So like they are more predictable in their approach. So here there is a decrease in heterogeneity. Participants are more homogeneous group is selected. Display endpoints of interest. That means prognostic enrichment is there. They know the endpoint very well. Then most likely respond to the intervention. So predictive enrichment is there. So this is another kind of enriched cohort study which can be chosen as a research design. Another research design is adaptive design. So as the trial progresses, depending on the observations, we can change our groups. For example, if we feel like placebos are non-responders, so we can include the placebo in the intervention group. So this is an adaptive design which depends upon the progression of the trial. Now, drug dosing paradigms which are used for proof of concept studies are either single dose administration or multiple dose or step up dose pattern can be used. So single dose is like single administration of the intervention, whatever intervention, it may be a drug or it may be an intervention, and then randomized with placebo. Evaluate short-term follow-up periods or longer-term follow-up periods can also be evaluated using this paradigm. Another one is multiple dose or dose ranging. For example, different dose of an agent and analyzing to evaluate most effective dose with fewest side effects. So these are the two dosing methods which are most commonly used in these early phase clinical trials. Now, there are so many drugs and analgesics which are introduced, which are there in the market. But out of those, the most successful one are opioid NSAIDs. Others are also successful, GABA modulators and TRP1, V1 modulator and cannabinoid voltage-gated sodium channel. But most commonly, most successful stories are those of opioids and NSAIDs. And still today, even though there are many opioids and NSAIDs most commonly are approved for clinical use, still today 83 new molecules of opioids are in early clinical stage trial. And similarly, 47 NSAID new molecules are in early clinical stage trial. Similarly, 43 for voltage-gated sodium channel, 34 for cannabinoid, 16 for NMDA. So likewise, still a lot of drugs are, a lot of molecule, this 83 is a big number, are still in early phase clinical trial. So that means we are in need of better analgesics or better treatment options. And if you look at the profile of mechanism of action, as Professor Matsuka said, we need to select a place where our target is located and where we want our drug to attach to. So for example, I said opioid receptors are located all over the body. So they are present in the brain also, they are present in the periphery also. But we cannot say whether when we gave opioid to a person, we cannot say which effect is shown. It was the effect on the central nervous system, or was the effect which we are observing is because of the engagement of the peripheral nervous system. So similarly, if you see drug number 3, which is a sodium channel inhibitor, so it has effect in the dorsal, it has receptors which it can bind in the dorsal horn in the spine as well as in the peripheral nerves. So different mechanism can be affected by a single drug, or a single drug can engage many targets. So that is one very challenging aspect when we think about the translatability of a drug. Now, I will discuss the proof of mechanism and proof of concept of only 2 drugs, opioids and NSAIDs, which are most commonly used. So opioids, we know mu-opioid receptors, right? So they are present, as I said, peripherally and in the central nervous system, and they have wide range of pain indications that opioids can treat. But there are big adverse effects also. One is addiction, another one is respiratory depression following opioid, either dosing or overdosing. So this is both the effects are very long-term, very harmful. One is short-term harmful, one is long-term harmful. And then second thing is that there is after a certain period of time, people become non-responsive to opioid therapy because of the activation of different pathway. Rather than the same pathway which we wanted to engage after some time or some period of time, it starts. There are different pathways which are activated, and they tend to prevent its primary action for which it is intended to use. So approximately a third of the opioids not only target mu-opioid receptors, but also antagonize the delta and kappa opioid receptors. They are also abundantly available throughout the body, and they are not delta opioid receptors are basically present in the brain, basal ganglion, and neocortical regions. Now, proof of mechanism studies of opioids are used to check the drug potency, administration route, drug efficacy, and action duration. So the most commonly test which is used to check the effect, the proof of mechanism of opioids is meiosis using pupillometry. So again, as I told you, we do not know whether it is because of a peripheral effect or because of the central effect. So that question mark will always be there. So it is difficult to determine. Now, one thing is that. Second thing is that we need a pupillometry to check the meiosis. So we have to depend on some equipment to show the results. Next is we can check the efficacy of the effect of opioids by using functional MRI technique, which shows the hemodynamic responses associated with neuronal activation in the brain matrix following nociceptive stimulation. Again, for this we need to depend on very expensive equipment, that is MRI. Now, other tests which can be done a little easily are like contact heat evoked potential stimulator, which affect the brain areas with opioid receptors. But still, we need to check the brain. Again, we need functional MRI for that. Now, because we want to check if the drug, the new opioid which we are going to use, induce side effect or not. So as I said, respiratory depression is one of the very adverse side effect. So for that, we need to check the dynamic and tidal forcing technique. And then abuse potential of the drug is very high for opioids. So changes on a drug liking by checking a visual analog scale is one method we can use. Next is opioids causes constipation. So motility of bowel is again a measure to see if it is affecting the gastrointestinal tract or not. And the tests which are used to check the proof of concept of opioids is cold pressor test, which demonstrates the analgesic effects in experimental context as well as in clinical context. Another class of drug which I would like to describe, because we are using NSAIDs most commonly. So they target, and it is possibility that we would like to check some new NSAID in our patients or in healthy human subjects. So the target for NSAIDs is, we all know the pathway. It engages this, inhibits the COX enzymes, COX-1 and COX-2. So the side effects are classic non-selective NSAIDs causes gastrointestinal bleed, which is attributable to COX-1 inhibition, whereas selective inhibition of COX-2 causes cardiovascular side effect. So drugs which are currently being developed and belonging to this class are primarily non-selective COX inhibitors, which are most commonly marketed. And new formulations are by being combined with another drug and developed as a single treatment. So that is one common drug. So proof of mechanism of NSAIDs involved, like we can check for a biomarker in the blood to see the effect of NSAIDs. For example, effect on PGE2, prostaglandin E2, and thromboxane B2 level determination can help to evaluate whether the how much effective NSAID is and which pathway it elicits. And then we can also check the concentration of drug needed to inhibit COX-2 by 80%. So versus effective concentration at COX-1 can be used as proof of a specificity test. Now, for checking the proof of concept of NSAIDs, we can use sunburn models, which are very primarily used as a readout for POC. These models have show robust responses to NSAIDs such as ibuprofen. So already these models are being used for checking the efficacy of various NSAIDs. Freeze injury model can also be used in combination with von Frey-Filament test. And there is one problem with these tests is that they cause post-inflammatory hyperpigmentation marks on the study subjects, which last for a very long time. So that is not acceptable to many human volunteers. And then we need to have more homogeneous study population, as it has been shown that these tests are more safer in lighter skinned people than in dark colored person. So we need to have homogeneous population because skin color may affect the outcome of the test. Other acute pain models, as I told you, dental impaction, third molar impaction model is the most sensitive to as an acute pain model in clinics. Then another one is bunionectomy model, bunionectomy surgery models, joint replacement surgery models, and soft tissue surgery models, which are most commonly used acute pain models in the how to say post-operative setup, and to check the efficacy of the NSAIDs. Now, what is the importance of these studies? They are translatory step between preclinical studies and studies in the relevant patient population. So they are like the first signal of clinical efficacy. So they are first in human, single or multiple ascending doses subjects, studies that are mandatory part of any drug's development trajectory. So each technique mentioned does provide a firm handhold for assessing POM or POC, and that development of each unique compound needs a tailor-made approach, as I talked about previously. So for every compound, every new molecule should have a very specific design. It is not possible to use the same proof of mechanism study design for opioids and for NSAIDs. The study design has to be different depending upon the pathway and the mechanism of action of the drug. Now, Now, this is towards the end. I would like to say that this hierarchy of evidence of pyramid shows that in vitro studies and animal lab studies lies at the lowest level, but the research goes from down to up. It cannot go from up to down. Up to down is also possible. That is called as a reverse translation study. But first, it has to be from a lower level to the upper level. Okay, so. And what we see is the clinical applications is the tip of the iceberg, which is very low, in number. Like many drugs are being tried in academic findings, in cohort studies, case control studies, case report. But there are very few drugs which reached the top, which are good enough to be used in clinical applications. So I would like to summarize my topic by saying that it's difficult to link animal and human findings, but it is necessary a step which we cannot avoid. Provide evidence that the hypothesized mechanism is affected by the drug. So it is necessary, evidence-based is necessary. Like in the previous slides, we see as we go up in the hierarchy, the quality of evidence increases and the risk of bias decreases. So it is necessary to translate whatever we study in the preclinical labs or in the bench, and then provide evidence that the effect on the mechanism leads to a desired short-term clinical outcome. Provide guidance for designing initial clinical endpoints trials that use a plausibility useful dose range. So all these steps are necessary to are the aim of performing the proof of mechanism or proof of concept study. So thank you very much. This was a very short lecture about translation study. The research is huge on this topic. Thank you very much for your time here. Thank you.
Thank you so much, ma'am, for a power-packed session. The lecture was very informative and engaging. Now, I call upon the audience to ask questions.
I have a question. Hello, ma'am.
Yes.
In human experimental models, ma'am, is there any test to check the efficacy of drug for visceral pain, ma'am? Because in cold pressure test or contact test, those are used for the superficial skin pain, ma'am.
There are models to check the visceral pain, and I'm not sure about it, but there are models to check. There are tests to see the results. As I said, pain can be in any part of the body, but test, for example, neuroimaging tests. So we check the hemodynamics of the brain when a test model is induced, and we check the pattern created, like excitability or change in the blood circulation level in different parts of the brain. So it is possible by neuroimaging. That is the best. That is the most, not the best. I cannot say it's the best, but these are the happening tests, and they have future implications for these kind of models.
Okay, ma'am. Thank you, ma'am.
Any more questions from the audience side?
Ma'am, I have a question. Ma'am, is there an animal model which can feel the pain just like human beings? Like, how do we come to know how much? Because since even within human beings, the pain is a subjective phenomena, then how are we able to translate their feeling of pain to the human model? Microphone.
Ma'am, please turn on your microphone.
Okay, so as I said earlier, that there is no model which is 100% replica of human model. In human beings, what we are checking is subjective and objective. There are objective questionnaires which can say that we have or neuroimaging technique which can check the pain responses objectively, but most of them they are checking the pain effect on the brain. Whereas in animals, we cannot ask an animal how much pain it has. So either we depend on there are various face scales, grimace scales to check the behavior of the animal. So most of the time we are checking the animal's behavior after inducing a pain model. For example, we check like the study which the video which Professor Matsuka says. So if we induce orofacial pain, and animal is drinking the milk through a thermos, so its tolerance and its threshold will decrease, and that will be reflected in the amount of milk it drank or the amount of contact it made with the thermos. So that level is different. That is checking actually the spinal response of the pain. So this is a very big difference, and that's why the translation research is very, very challenging from animal model to human model. But that is what we have, and that's why human models are also used in early clinical stage trials. So Sidra Aslam asked what all characteristics human subjects should have common in case of orofacial pain research. So I said it's tailor-made approach. So it depends on which drug we are going to check and what are the intentions we are going to use it for. First thing. So for example, we are checking a drug for osteoarthritis. Yes, physiology varies with age, gender, including pain intensity, tolerance, threshold, everything changes. So most commonly, it depends on the stage of trial. So proof of mechanism, we prefer to use a homogeneous population. But when we go at higher level, we choose bigger sample size, and rather than human subjects, healthy volunteers, we choose pain conditions. So initially we focus on a very homogeneous population which has similar pain conditions, similar symptoms, and similar characteristics. And then from there, if it is approved, it shows positive signs, we go to a bigger human model. So human population or cohort. So bigger the cohort, the homogeneity of the population changes. So it is step by step. It cannot be like, it depends on which stage you are. So that is not only for orofacial pain research, that is for all the research, for all the drug development, that this is the way we have to proceed from the bottom to the top. And reverse translation is also possible. Is it okay? Thank you.
Now I think the question and answer round is over for the session. Now I will now I think time is over for this question answer session. Now I request Dr. Matsuka sir to throw some light on the topic of chemical transmitters and non-neural mechanism in pain control. Over to you, sir.
Thank you, Dr. Ziba. So this is the last presentation. So it's good, huh? Oh, sorry. Just a moment. I will start the slides.
Okay, sir.
Can you see my slides?
Yes, sir, they are visible.
All right, thank you. So I will talk about the chemical transmitters and non-neural mechanism in pain control. So this picture is, again, Tokushima, like Grand Canyon, United States, but small Grand Canyon. You can come to see. All right, so after damage of orofacial pain, orofacial skin, or oral mucosa tooth muscle or temporal mandibula joint, the nociception works and pain transmission in C and A delta fiber go through the trigeminal ganglion spinal cord and feel pain in the brain. I showed you many times. So actually my target is sensory ganglia. So our hypothesis is that neurotransmitter release from sensory ganglia is related to the pain transmission. Because although there is no synapse in the sensory ganglia, and I showed this picture before, chemical mediated cross excitation in sensory ganglia is reported from the other laboratory. So some research groups showed similar data. So my research hypothesis was neurotransmitter release within sensory ganglia is related to the neuropathic pain transmission, and decreasing neurotransmitter release induced the pain relief. So research steps I thought was neurotransmitter release from sensory ganglia and cell body. I want to check, and also check the neurotransmitter release change in pain model. Also, I want to have the clinical management idea. So the first study was like this. So I made a neuropathic pain model, hind paw model. So not orofacial pain, sorry. So I put some sciatic nerve entrapment, and the rat has pain. So rat reduced the mechanical threshold. So after making the SNV, sciatic nerve entrapment, the pain, the rat feels pain. Rat has pain threshold. Rat has pain behavior. Sorry. So decrease hind paw visual threshold after SNE. Then I took out the trigeminal, dorsal ganglia, not trigeminal ganglia, dorsal ganglia, and I perfused. And we developed an ex vivo DRG preparation for extracellular ATP measurements. So I collect the samples and I check the ATP level. ATP is again the neurotransmitters. Then I found that this is a control. This is a SNE. So sciatic nerve entrapment. So baseline levels increased. The baseline is increased. ATP levels increased, and after stimulation, the ATP is not released after with the stimulation. So basal levels increased in the pain model that we found. So the rat hind paw neuropathic pain model suggested that the neuropathic pain increased the neurotransmitter release from sensory ganglia. So this is again hind paw neuropathic pain. How about trigeminal neuropathic pain model or facial pain? So I did microdialysis in vivo and checked the release of ATP and substance P within trigeminal ganglia. So I insert the microdialysis probe and I put some artificial cerebrospinal fluid like saline, we call saline, right? And I will get out the fluid. And I check the ATP level and also substance P level. And it's a normal rat, naive rat. Naive, not rat, guinea pig, naive one. Then after the stimulation, after the chemical stimulation, I saw the ATP and substance P increased. Then I made, actually, Dr. Newbert made inflammatory pain model. So increased substance P release in inflammatory pain model. So he injected turpentine oil, inflammatory soup, inflammatory drug, turpentine oil, and injected. It's very painful. Acute pain is the acute pain model. Acute inflammation model. Then he injected he inserted the microdialysis probe and checked the substance P in the fluid. So the turpentine oil side is a gray color. So in the baseline is also increased. Also after the stimulation, chemical stimulation, more substance P is found in the fluid. So inflammatory pain side trigeminal ganglia showed higher substance P release. So neural stimulation with potassium chloride induced more substance P release be found. Then I wanted to know these kind of the release from the cell body. So I did capacitance recording, capacitance measurement. It's difficult. Electrophysiology, right? So it's this picture is the patch clamp. So I dissociate each neuron and cells, and I put a small thin electron on the neuron on the cells. Then I did a forceps patch clamp. I did forceps patch clamp, not outside out, just forceps patch clamp. I did. Then I found that stimulation of the trigeminal ganglion cell induced the calcium influx, of course, and increased the capacitance. So capacitance is increased. It showed that the trigeminal ganglion cell has a vesicular release. So the vesicle binds to the membrane, then capacitance increased. So stimulation induced vesicle binding to the cell membrane and the neurotransmitter release I found. So we can say that we have some release in the trigeminal ganglia, and also that I found that the trigeminal ganglion neuron itself released maybe released something vesicular release. And so we found that the neurotransmitters are released within trigeminal ganglia, and the neuronal stimulation increased the release level. The neurotransmitters may be released from cell body. The orofacial pain model increased the neurotransmitter release also, inflammation model. But how can we connect to a new treatment? So that is my idea. I wrote here DNA, but we can inject something in the peripheral skin, and so that molecule go to the trigeminal ganglia or sensory ganglia, and then if these molecules decrease neurotransmitter release, we can decrease the pain. That is a new treatment idea. So I was looking for the what kind of molecule we should use. So I found one of the candidates of botulinum toxin type A. Botulinum toxin is commonly used for the blepharospasm and strabismus, upper motor neuron syndrome, cervical dystonia, chronic migraine, and cosmetics. And also in Korea, many other tried. In the clinical use the bruxisms, master muscle hypertrophy, etc., etc. So the botulinum toxin blocks the vesicular neurotransmitter release I showed one time before. So if we inject the botulinum toxin periphery and botulinum toxin go to the trigeminal ganglia and decrease the neurotransmitter release, is okay. So I used the botulinum toxin, and I talked with the Professor Oguma at Okayama University, and Dr. Oguma said, no, it's impossible. It's impossible, he said. You cannot get the data, she said. So, but I did. So research strategy on developing the botulinum toxin treatment for orofacial pain. So I wanted check the botulinum toxin reduces orofacial pain, and also the botulinum toxin mechanisms for orofacial pain I wanted to know, and also I wanted to start a clinical trial. So we made the infraorbital nerve constriction rat model. So and we check the pressure, head withdrawal threshold, and after the infraorbital nerve constriction, the red one, the rat has pain, so the head withdrawal thresholds go down, and it's a sham surgery. We didn't constrict the nerve, just open the face. Then no change, right? And after the inflammatory nerve constriction, the botulinum toxin injection, a little bit pain behavior is better. So botulinum toxin A alleviates the inflammatory nerve constriction, induced decreases in withdrawal threshold to mechanical stimuli. So looks like botulinum toxin decrease the pain. of the neuropathic pain. And also we did the operant model. I showed the previous presentation, that heat stimulation I did. Then this is a normal level. So after the infraorbital nerve constriction, the rat has pain, so they don't want to touch the heat pipe. Then I inject the botulinum toxin, and when I inject the botulinum toxin 200 picogram, like 20 mLD, 20 unit, the rat didn't have pain. So pain recovered to behavior recovered to the normal level. Sham surgery is same as the sham operation. And also we inject the botulinum toxin antibody. Antibody itself, and botulinum toxin antibody and botulinum toxin didn't decrease the pain. So botulinum toxin worked for the pain, for the neuropathic pain, that we can say. And so what happened? I want to know what happened in the trigeminal ganglia. So I did the infraorbital nerve constriction and checked the behavior, and we found a pain and botulinum toxin peripheral injection. Then we observed in the I did the cell culture, and I observed the FM464 vesicular release with confocal laser microscope. FM464 is like this. So we dissociate the neurons, many neurons on the dish. Then here the vesicles. So when we put the FM464 with stimulation, the FM464 enter the vesicles. Then after washing, we see the FM464 in the vesicles. That is this image. So you can see the FM464 in the vesicles. Then I stimulated again without FM464, just stimulation. So after stimulation, the vesicles released from the vesicles. FM464 is released from vesicles, so almost nothing. I used that FM464. So then I found that botulinum toxin injection rat, that's a infraorbital nerve constriction pain model. So if we don't inject the botulinum toxin, the FM464 is released much, almost nothing. But if we inject the botulinum toxin, the FM464 is not released much. So the conclusion, the botulinum toxin injection reduced the vesicular release in the trigeminal ganglia after injecting the peripheral nerve, I found. And also we want to know the botulinum toxin it goes enter the trigeminal ganglia neurons. So we did the trigeminal ganglion cell culture, and we use the botulinum toxin heavy chain and Alexa 488. Alexa 488 is just green color. Then I checked, and I found that the botulinum toxin enter the neurons. So it's a much confocal image. So this Alexa only didn't go enter the botulinum toxin into the neuron. Then we inject the botulinum toxin into the peripheral site with green color. Then check dissociate the neurons. Then I found that not in this case, not dissociation, just histology, just a histochemical study. Can you see the difference though? So localization botulinum toxin type A heavy chain in trigeminal ganglia after peripheral injection. So I found that after injection of the botulinum toxin into the sensory area, the botulinum toxin go to the trigeminal ganglia and enter the trigeminal ganglion neuron. And also when I use the colchicine. Colchicine blocks the neurotransmitting, so blocks the neuron, blocks the moving in the neuron, moving in the nerve. Colchicine blocks the moving in the nerve. So after blocking the botulinum toxins decreased like these slides. So subcutaneous injected botulinum toxin heavy chain was identified at the trigeminal ganglion neurons. This uptake was inhibited by cold hitching treatment, which blocks axonal transport. So you don't need. So okay. So botulinum toxin heavy chain was endocytosed into trigeminal ganglion neurons. Uptake botulinum toxin heavy chain was inhibited under the anti-SV2C antibody compared with the control. So anti-SV2C is a receptor of the botulinum toxin that we found. So this is a botulinum toxin study conclusion. So peripheral administration botulinum toxin A have a pain control effect by inhibiting neurotransmitter release in the trigeminal ganglion cells. Consequently, there is a possibility that peripheral administration botulinum toxin A inhibits pain transmission to secondary neurons and the central nervous system. So after inject the botulinum toxin, and the botulinum toxin go to the neurons and block the neurotransmitter release, decrease the neurotransmitter release, and pain reduction will happen. Is happening. I thought. All right. So that is the botulinum toxin studies conclusion. And also the yeah. Okay. And also, trigeminal ganglion neuron I showed many times this picture. Satellite cell and macrophage communication following trigeminal nerve injury. Following trigeminal nerve injury, trigeminal ganglion neurons become hyperactive, and various molecules are generated and released from trigeminal neurons. Subsequently, satellite glia cells and macrophages are activated. These mechanisms are involved in ectopic orofacial pain associated with trigeminal nerve injury. So we found that both the neuron itself released some ATP or substance P, and we can block this kind of the neuronal release with the botulinum toxin. But we found also, we learned the bottom neuron has is surrounded by the satellite glia cells. So we need to know the communication between the satellite glia cell and neuron. So also that this non-neuronal transmission interaction between distinct parts of the nociceptor with different types of non-neuronal cells. Again, the sensory ganglion neuron has the satellite glia cells around it. So we want to know the mechanisms. So the actually Dr. Shaista's studies here. Cytokine release from satellite glia in trigeminal ganglia. So she did acute dissociation of the trigeminal ganglion. And at the 37 degree using 0.25 milligram trypsin, 1 milligram collagenase, and 0.2 milligram DNA. So dissociation. Cells were centrifuged and resuspended in culture medium and plated in 24-well plate. And this is a picture. So cell culture. This is a primary culture. So she found neurons and the satellite glia cells and on the dish. And we wanted to have the only satellite glia cells because we want to know that satellite glia cells release a cytokine. So satellite glia cells purified culture. What she did was prepared by treating 0.5% trypsin and 0.2% ethylene diamine tetraacetic acid at 37 degrees and resuspended into fresh culture medium. Means, so neurons easily to die, and satellite glia cells not easily to die. So we did some cell culture again. So satellite glia cells survives. So percentage of the satellite glia cells increase. And after that, stimulation of the cells by exposing the cells to 1 micromolar CGRP, calcitonin gene related peptide, she added the CGRP into the satellite glial cells and collect the supernatant after overnight incubation, and then analyze the cytokine release using cytokine array. So this is the data of cytokine array. So after stimulation, the glia cells release IL-3, fructaalkaline, and CNTF or blah blah blah, IL-2 or many things. So we have we can say that, oh yeah, satellite glia cells release these kind of cytokines. So this is what she did. So infraorbital nerve constriction, pain behavior of the orofacial pain model, transient ganglion tissue, then cytokine array. And also actually first author is Dr. Iwasa, but Professor Shaista did this study also. So actually Dr. Iwasa made neuropathic pain, then constriction model, then 1 day later, 7 days later, 14 days later, he collected the tissue and Shaista dissociated. Then check which cytokines increased or decreased. And so these are data. Let's say CXCL2 is 1 day that increased, then 14 days later decreased. So this is CXCL2. And IL-10 is anti-inflammatory cytokines. First days are low, but 14 days increased. So there are several types of the cytokines released in the trigeminal ganglion model. So this is the pictures. So the satellite glia cells release the cytokines, these kind of cytokines, and also these kind of cytokines affect to the sensory ganglia neurons and increase the pain sensation more, right? Okay, and then how can we decrease the pain? So Professor Shaista did the minocycline injection into the sensory ganglia directly. Then she found 6 hours later after minocycline injection, the pains reduced. So, because this is a heat stimulation, right? So the pains reduced with the minocycline injection. She found also after injection of the minocycline, which one? Yeah. So after minocycline injection, GFAP is decreased. GFAP levels decreased means the GFAP levels decreased means the glial activation. Glia is activated with the pain model, and the minocycline injection reduced the glia's activation. Also, she found. Okay, sorry. So this is the summary. So after the pain model, if we inject anti-inflammatory cytokine IL-10 or anti-CXCL2 injection into the trigeminal ganglia, pain is decreased. Cytokine application to trigeminal ganglia decreased the pain. Also, the minocycline application to trigeminal ganglia also decreased the pain, and also the minocycline decreased the glial cell activation we found. All right. So we have one more botulinum toxin study. Recently, Arif was reported in toxins. And so he made a cisplatin injection, and he made cisplatin, the anti-cancer drug. So systemically inject the cisplatin anti-cancer drug, induce the orofacial pain. Yeah, neuropathic pain we already reported. Then he inject the botulinum toxin in one side, and after in peripheral side, after inject the botulinum toxin, the pain is reduced. So pain behavior came back to the normal. But he found that not the injection side, contralateral side pain also decreased. So means the rat had a systematic neuropathic pain, and he injected the right side. Let's say right side, he injected the botulinum toxin. Pain is reduced in the right side. Also, the left side also pain is reduced. It's interesting. So also he found that the botulinum toxin go to the nerve and go to the trigeminal ganglia, contralateral side trigeminal ganglia. He reported. It's interesting story, isn't it? Also, this is almost last slides, last session. So we have some drugs. I reported yesterday some drugs for neuropathic pain: gabapentinoids, pregabalin, gabapentin, tricyclic antidepressants. I told you, and noradrenaline reuptake inhibitor, also opioids, and botulinum toxin. So the review reported this pregabalin or gabapentin target is alpha 2 delta 1 calcium auxiliary subunit of voltage gated calcium channels, and tricyclic antidepressant target is a noradrenaline serotonin uptake systems, and opioid has opioid receptors and the noradrenaline serotonin uptake system. And cannabinoids, the CB1, CB2 receptors, botulinum toxin, and neurotransmitter release. And status is gabapentinoid, tricyclic antidepressants, noradrenaline reuptake inhibitors, a first line treatment, and opioid the second line, cannabinoids the third line, botulinum toxin fourth line treatment. But still we can use. So in the last session, I will show what is the mechanism of these kind of drugs. So mechanism of gabapentinoids. When levels of alpha 2 delta 1 are normal, its accumulation in nerve terminals is controlled by transport along primary afferent fibers from cell body to the dorsal horn. So this is the alpha 2 delta 1 subunit. So slow transport and also rapid cycling in the nerve terminals. Then it broke the calcium channels. That is a mechanism of gabapentinoids. Oh, sorry. So this is a mechanism of antidepressant. The drugs inhibit uptake of norepinephrine and the serotonin into the presynaptic neuron. The side effects include postural hypotension, sedation, dry mouth, and constipation and blood vision. So antidepressants block the noradrenaline and serotonin reuptake, blocks the receptors. And opioid is affect the opioid receptor. Morphine and other opioid agonists activate presynaptic mu, delta, or kappa opioid receptors on primary affect neurons. These receptors coupled negatively to adenyl cyclase via G protein inhibition of cyclic AMP formation leads to opening of potassium channel and closing of calcium channel. That is mechanisms. Also, the cannabinoids. Cannabinoids bind to the CB1 receptor and CB2 receptor. Neurotransmitter from presynaptic neuron triggers the postsynaptic neurons, stimulate the postsynaptic neuron release endocannabinoids. Endogenous CB1 ligand binds to the presynaptic PGMA receptor. And so this is a kind of the cannabinoids mechanisms. And mechanism botulinum toxin, I told you many times, botulinum toxin blocks the neurotransmitter release. Okay, and also the NMDA receptor and the GABA A receptor. NMDA receptor is if these kind of these things binds the glycine receptor, NMDA receptor, and open and sodium and calcium enter. GABA A receptor also same, the influx of the chloride ions through the pore. So hyperpolarization of the neural membrane and inhibition of neurotransmission. The GABA A receptor. GABA A receptor blocks the pain also. So this is almost last slide. TRPV1 channel also affect to the pain modulation. Okay, all right. So thank you for your kind attention for 5 days. And I want to come to India and see your reaction in the lecture. So online lecture is difficult for me. Thank you very much. Dr. Ziba, do you have some questions?
Thank you so much, sir, for sharing your knowledge with us. I think, sir, audience are waiting for your answers. I think they might be having questions, sir. And I'm sure the lecture has compelled everyone to think about the issue and look at the different aspect of the orofacial pain through a different lens. Now I request all the participants to come forward with their valuable questions.
It's okay. It's okay.
Hello, sir.
Yes, yes,
Hello, sir. I have a question, sir.
yes.
Sir, you told the first line drug, diloxin, is there for neuropathic pain.
Just a moment. First line drugs, what?
Diloxin, sir.
I thought the first line drug is
First line, sir. First line.
First
drug.
line, yeah, first line is pregabalin, gabapentin, tricyclic antidepressant, noradrenaline, SNRI, SSRI. I told you.
Sir, do you prescribe all these in Japan?
Yeah, we can. I can. Yes, for the trigeminal neuralgia.
Okay, sir.
I think in India also same, right? I believe.
So in this session, you can ask questions related to previous lectures also. It is not necessary to ask related to this lecture. Is it okay? I think it's okay.
How you decide which patient to treat with Chinese medicine? Thank you for the question. When I use the Chinese medicine, I said many times. I said Chinese medicine many times. The patient has many drugs already. This kind of patient, I use Chinese medicine. Also, if patient has a severe side effects of many drugs, I use Chinese medicine. Also, what else? Oh, the pregnant patients, also we can use Chinese medicine. Also what? Also the patient, like in Japan, some patients love Chinese medicine, Chinese herbal medicine. So in this case, I use Chinese medicine. It's okay. Medically compromised. Yes, you are right. You are right. Medically compromised hypertensive diabetes also same. Yes, thank you.
So yesterday, one of the participants, I think Sidra asked them the same one who asked you Chinese medicine question. She found the formulation similar to the Chinese formulation you sent, little similar, but it's not popular for use for neuropathic pain. Yesterday you sent the composition of yeah, so she did little search and she found some of the herbs similar to the one used in Chinese medicine are here in Unani medicine in India.
Good.
But we are not using it. We didn't know actually. Now we will maybe we will think about using it. So do you plan, Machika Sensei, to do some studies to check the mechanism of action of these Chinese medicine and like which pain mechanism they are affecting?
Yeah, it's good research, huh? So Arif wants to know. So Arif sent the new patient, new student to my lab, and Arif wants him to do the Chinese medicine study. Maybe he will do in Indonesia. Or you can.
We do not have right now say animal study setup. But yeah. So you can ask anything. It is not related to today's lecture only.
Good morning, sir. Sir, I have a question. Like, sir, do you have any traditional Japanese cure for the pain as well? Like, there are cures all across the world. We have cure for pain, traditional pain. So, do you have any?
Japanese traditional treatment? You asking, right? Maybe meditation. Meditation is traditional Japanese medicine. I don't know that. Sorry. Actually, okay. I don't know the traditional Japanese medicine.
Okay, sir.
I need to check. Thank you.
Okay. Thank you.
Hello, sir. Sir, I have a question.
Yes. Yes.
So, sir, after the administration of botulinum toxin in the mice, sir, in the rats, sorry, sir, after was there any? Hello, sir. Am I audible?
Yes. Oh, you are. Please turn on the microphone.
Okay.
Oops.
Sir, after the administration of botulinum toxin in the mice, sir, after how much time did the pain come back, sir? Or for how much time did you find the relief in the rats?
Good question. We didn't check how long the botulinum toxin reduced the pain, because in the human being, we keep usually the botulinum toxin effect works for 6 months, 3 to 6 months. So maybe I checked at least 2 weeks. The effect is, we can see the effect for at least 2 weeks. But we didn't check carefully how many days later, how many months later it comes back. Thank you.
So, sir, was there? Sir, I have one more question. So, was there any immune response to the botulinum toxin, sir, when it was injected in trigeminal, sir, in peripheral nerves, sir, because it can induce like antibody response also, sir. Sir.
Yeah, good question. Also, here. So I can show the slide again. I didn't tell you the detail. Can you see my slides? Yeah. Can you see the slides?
Yes, sir.
Yes,
It's visible.
Or can you make bigger? Do you want to make? I can make bigger. So botulinum toxin, the commercially available botulinum toxin has this. So neurotoxin and the non-toxic and hematoagglutination they have commercially available. So these things sometimes induce the antigen antibody effect. So some not all, very few patients had immune response. So in this study, actually Dr. Oguma developed the only neurotoxin. So I used the only neurotoxin in the research. Sorry. So some report said, some papers reported these kind of the non-toxic things induce the immune response. Thank you.
So in the study in which you created a cancer chemotherapeutic neuropathic pain model, so the botulinum toxin was injected unilaterally, but the effect was found bilaterally.
Yes, you are right.
So what do you think it was, the mechanism of action was? And you found that the botulinum toxin was there in the neurons only, not in the glial cells of the trigeminal ganglion. On the contralateral side also, or only on the ipsilateral, both sides? Both sides,
bilateral side.
So what was the reason for transport, like from right to left or left to right transport? Within the ganglion, it's cross excitation, but on the opposite ganglion, what could be the reason?
So we think we need to find the mechanisms, but maybe this injection go to the spinal cord, and in the spinal cord there are some connection right and left, and then go to the contralateral side, we think, but we don't know. We want to know which part of the brain the botulinum toxin moved to right and left. We want to know. And also he found that some botulinum toxin go to the blood. 18% of the botulinum toxin go to the blood. So the bloodstream bring to the contralateral side also, we think.
So, okay, I understand what you said. So one more thing is that this botulinum toxin effect is due to the its peripheral effect on the peripheral nervous system, right? Peripheral ganglion. But is there some localized effect also? Like, did you see any changes in the local tissues, like recruitment of more number of anti-inflammatory cells or more number of macrophages? So did you see any such effect?
Good question. Yeah, of course, the botulinum toxin reduced the acetylcholine release from the nerve endings. So we think we have the peripheral side effect, but we didn't check carefully the peripheral side effect, just only the trigeminal ganglion. We checked. So we need to do these kind of experiment also. Thank you.
Sir, are there any adverse reactions related to botulinum toxin?
Adverse effect?
Adverse effects, sir. Side effects.
Yeah, adverse effect is the patient cannot chew well. So just a moment. Can I talk a little bit, because the Dean wants to talk. Sorry, my dean wants to talk. Your dean.
Okay, it's okay, sir.
He will enter soon. So it's okay.
So in human being, do you think it is the same mechanism of action which we saw in the rodent models? We didn't know. We don't know. Or there are some neuro
Which one? Which
imaging
botulinum toxin?
effect of axonal transport.
Yeah,
peripheral ganglia.
we don't know that because we don't know because we didn't
We
check
cannot
the
check.
but I believe it's same. I believe. So, Shaista, Dr. Baba, Dean Baba, will enter this meeting soon.
Yes. 11:30. We have 4 more minutes. I'm waiting for just a second. Okay, so our Dean will also be joining soon. He's in OPD actually. So he's joining soon. So but Baba Sensei has not yet. Hello.
Hi, moshi.
Dr. Shaista, both the deans have the link of Zoom. No, they are with the link so that they can easily enter into the meeting room.
Yeah, I already gave them the link.
Okay.
I think Professor Baba from Tokushima University, Dean Tokushima University, is waiting to join. And
Okay.
But
I think
wait, Dr. Baba doesn't remember the password.
Oh, he doesn't remember Zoom password.
Right.
It's his password.
Yeah. Right.
So maybe he can create one new.
Huh?
We have 2 minutes. He can create new password.
He can enter
Hello.
through any
He can
Gmail.
go to Gmail.
Gmail.
No need to give the password if he is using the Gmail. Is Gmail usual in your Japan?
He has Gmail ID.
Yes.
Matsuka Sensei, does he?
Yeah, 覚えてます Gmail ID. He doesn't remember.
No, if he has Gmail ID, he can just log in using the Gmail ID without the need for password.
Hi. So what should we do?
Dr. Shaista, can you share the Gmail ID of Dr. Baba so that I can give him the alternate route to enter the meeting room? I can request my IT team so that they can make their ID, and through these students or these delegates, through the link they entered, he can also use that link. We can share on the WhatsApp.
Professor Matsuka, so can he give his Gmail ID? Does he remember his Gmail ID?
To you?
Just ID, not the password. Yes.
Yeah. Gmail address, right?
Yes, Gmail address.
Gmail のアドレスを先生教えてもらっていいですか？あ、わかんないですか？
He doesn't remember.
So he can make if he's not the Gmail ID, whatever ID he's supposed to create. I'm just sending a link and he just supposed to make his ID over there or change the password, that MedSkill link, and through that link he can enter directly to the meeting room without going to the Zoom link.
One thing, Professor Matsuka, is he very near to you? His room is very near to you, or is he very far away from you? So
it's close.
It's close. So he can come. Can he come to your office and both of you can join from the same?
入れなかったです。僕の部屋でって言ってますよ。いけそうですか。お。So he did.
I think he entered.
He entered?
Otto Baba, I think.
Oh, yeah. ありがとうございました。じゃあ、切りましょう、電話。はい、失礼します。
Welcome,
So
Baba Sensei.
Yeah, Baba
Professor Otto Baba Sensei. Welcome to the meeting. And also I can see Professor Varsi from Linguistic Department, who is the local coordinator of Global Initiative of Academic Networks from our university. He has also joined. So we are waiting only for, welcome sir. So we are waiting only for the Dean, Faculty of Medicine, Aligarh Muslim University to join. He is also coming. He said he is joining soon. So Professor R.K. Tiwari sir, are you there? You are there, sir. Please turn on.
Yes.
Good afternoon.
Good afternoon.
Good afternoon.
So today we have gathered. This time has been reserved to discuss new collaboration opportunities with between Dr. Zeri Dental College, Aligarh Muslim University, and Tokushima University, Japan. And we have as our members for this discussion, Professor Otto Baba, chairperson and dean and chairperson of Department of Oral and Maxillofacial Anatomy with us, and Professor Yoshizo Matsuka, who is our international speaker, and we have Professor R.K. Tiwari, who is the principal of Dr. Zeri Dental College, and Professor R.K. Bhargav will join soon. I think he is joining, and also we have our local coordinator, Dr. M.J. Varsi, with us for this discussion. So maybe we can we start, Matsuka Sensei?
Mm-hmm. Yeah, we can.
We are waiting for him to join, but I think he's on his way to his room and he will join in a while. So it's okay to start?
Yes.
Okay, thank you, Baba Sensei. Thank you, Matsuka Sensei. So, Tiwari sir, you can start with your...
Me?
Good morning to all esteemed members. I welcome you all on this international platform of academic exchange, and hope that our students have learned a lot, especially Master Shuka has presented so many articles, so many references, so many papers in the last 5 days, and it was very interesting. In the last slide, he said that I am willing to come to India, and I hope that we can arrange his visit to India. And I will be honored to host him as a guest speaker anytime in future in Aligarh Muslim University, India. And we just want to have some collaboration. Our institution, our college is 25-year-old. We have celebrated Silver Jubilee last year. And every year, the undergraduate students, 30 undergraduate students are passing from our institution, and almost 17 students of postgraduate are passing. So we have laboratories, we have dental college, all the specialists are there, and we seek your help in inter-exchange program with our students, with our teachers in Japan, and same from your side. So this is our desire, and I hope that you will help us in doing so. Thank you.
Thank you, Tiwari sir. So Matsuka Sensei and Baba Sensei, if you have to say something related to this.
Baba Sensei, どうぞ。先に言いましょうか。
You need to unmute yourself, Baba Sensei.
ミュートになってます。
Unmute, please. No. Yes.
Okay.
Now it's fine. Yes, it's fine now. Okay. Please go ahead.
Okay. Hello. My name is Otto Baba, Dean of Dentistry Dean of Faculty of Dentistry in Tokushima University, and I am also the professor of anatomy section. Today we have the first official meeting for our future collaborations between Dr. Zia Uddin Ahmad Dental College, Faculty of Medicine, Arigas Muslim University, and Faculty of Dentistry in Tokushima University. I believe this opportunity is really happy for both of us, and we appreciate your efforts to settle this first meeting. Thank you very much for Dean, Professor Rakesh Bhargava, Principal Professor Tiwari, and Dr. Shaista. Thank you very much. Currently, we have the active collaborations programs between the universities in Indonesia and Finland. Before the COVID-19 pandemic, we had the undergraduate students exchange program, even inbound and outbound. While under current conditions, we still have online program to keep our communication. Regarding the postgraduate program, currently the students from China, Indonesia, Philippines, in India are studying very hard and even enjoy their life in Tokushima. Yeah, it's I believe. Tokushima is a nice place, as Dr. Shaista knows. It is not so big town, but a hospitable environment for even Japanese with a mild climate, delicious foods, or so on. When we start the program and you come here, you may realize what I talk here. I know we have a couple of formal procedure. However, we wish our programs starts near future and both yours and our members enjoy their academic life through this collaboration. Hope the pandemic go away soon. Thank you.
Thank you, sir. Thank you very much. We hope pandemic. Yes, please.
Shaista? Dean sir will join through my ID. Okay?
Welcome,
hello,
sir. So he is Professor R.K. Bhargava. He is our dean, and he's also professor in the Department of Tuberculosis and Respiratory Diseases. And it's like a very, very huge OPD he has to handle. And today was his OPD day. And sorry, sir, we disturbed you in between, but your presence was needed actually, and your guidance is needed. So right now, just a few seconds back, Professor Otto Baba, who is the dean in Faculty of Dentistry, Tokushima University, he addressed us and he said, he said hello to you, and he is willing for such kind of collaboration. So I would like you to address them. Thank you, sir.
Thank you very much. I welcome Professor Otto from the Japan. And it's really our pleasure that you are addressing our students in the dental college. It's a great pleasure, and I hope that most of the students as well as the faculty members must have gained a lot from you, and especially from Japan. And we need such type of collaboration in future also, so that we can as faculty members, most of the faculty members will gain very much from them. I again welcome you here. Thank you.
Thank you, sir. Thank you very much. Tiwari sir, would you like to say?
I've already spoken sufficient, but definitely the exchange program will raise the academic standard of both the country. Both the country will visit, and if visit, they can see the lab, they can see the clinics, and accordingly they can upgrade their. So it is nice that we should have an exchange program with collaboration. And I hope that both the universities will facilitate the exchange program in future. Thank you very much.
Thank you, sir. Thank you. So one thing which we wanted to discuss, actually we cannot discuss, it's too early. But of course, the most important thing for any exchange, for any collaboration is money, funding. And right now we have collaboration. There are some collaborations, but they are like more of clinical collaborations. So in one department, oral and maxillofacial surgery department, they are going to start a collaboration with Hungary, and that is actually funded by European Union. And I don't know the conditions. I'm very honest about it. I don't know the terms and conditions about that collaboration. But this one is basically one of the, I think because we got the letter from the Ministry of Education, and because maybe Varsi sir can tell us better. So maybe if we can start a collaboration, we can seek for funding in India. But I would still like to ask Matsuka Sensei and Baba Sensei that what kind of funding opportunities for developing students from developing country can have in Japan and they from India, and they can. I know that students are studying and they are getting next scholarship that is funded from Japanese government. But if our students, like our college students, want to do some higher studies in Japan, so what will be your take about it? I'm sorry, I'm very straightforward, because funding is the most important thing for anybody to pursue higher education. I couldn't do my higher education until I had support from my university to have study leave and my salary paid by my university. That's true. So I can understand that's true. That stands true for everybody who belongs to either in Japan or India. Without funding, they cannot pursue higher studies. So what is your opinion, and what are the opportunities there? It is not necessary that you tell now. Maybe you can tell me later, or we can have more discussion about it. But if any, you can tell us now.
Okay, yeah, we can have the, we can talk later also. But for the undergraduate student, after the collaboration, after finishing the MOU, we can have the JASO. I know JASO is the Japanese Association
Student Scholarship.
The student scholarship.
Yeah, I got JASO for first year.
Yeah. And the undergrad student, the JASO will pay for the undergrad student was not much, but some. It was short duration exchange program. And also regarding the PhD program, PhD student, the Tokushima University has a scholarship. I think Dr. Shaista remembered.
There are many scholarships, but very difficult to get. It's not so easy to get, because my experience was that they have a priority. They have a priority list that the Indonesian students comes on top, and India is not on that list. Am I right or wrong?
So in Tokushima University, we have the Tokushima University Yume Scholarship. Also,
okay.
Dental school has a Shikoku Dental Association, Research Association Scholarship also. So actually, almost everybody can get.
Yeah, by default, yeah. yeah. That's also a good scholarship. At least we can pay something when we are living in Japan. Yeah. It's very expensive country. Even electric bills and winters shoot very high for us. We cannot live without air conditioners and heaters. It's so cold. So anyway, it's
PhD student can get the Otsuka Toshimi scholarship. Otsuka Toshimi, do you remember the?
I remember Rashmi got that with a lot of efforts. She got that.
And also the Monkasho's scholarship.
These are scholarships.
Government. I don't know, Japanese government scholarship.
Okay, so these are the scholarships students can apply to study there. So if we collaborate, so for example, so will our students get some privilege in getting those scholarships? Like our country come on the top, like below Indonesia or Mongolia, somewhere for scholarship preferences?
It's not related with the country.
I felt like it's related to collaborations, not country. Collaborations you have with different universities.
Yeah.
So it's related to collaborations or not?
Yeah, it's based on the kind of their ability, the appliers' abilities, applicants'
yes,
abilities.
Yeah, ability is important, of course, to get any opportunities. Yeah. Ability is very important.
So the students may need to get some good marks during during their studies in universities or postgraduate course.
Yes, I know that. I remember that when one of the students from India was being recommended by Professor Matsuka for a master scholarship. So her grades, which she got at the university level in India, were considered. But our students don't get very good grades. It's not because their ability is less, because our marking system is very difficult. So it's difficult to score 80% or 90% in our university, I'm telling you very frankly. So 60% is okay. You can find many students getting 60%. So that is one very, I think we all understand that. All the students who are here, they know that they don't get 80% marks. So there they get out of the list. So I think instead of marking system, if there is some test, entrance test is there, but it's very simple test. So that is not for the scholarship. So anyway, that is one thing. That is one thing, one aspect.
Now it's time to consider the changing the mark, change the system.
Tiwari sir, Tiwari sir will tell. Tiwari sir will tell.
We are changing a lot from so many days because our students are quite capable, but because of marking system, they are getting very less number. And if you have any competition, a small competition for entry in Japan, it will be better. And then I hope that our students will succeed in getting admission in your university or for a scholarship or anything. So we can arrange a small online few questions for all over, for the persons all over the world, not for India only. And then you can choose from them. You can see the priority according to the marks obtained in the test. So that is my perspective of in this regard. Thank you.
Anyway, so that is one thing. One more thing I want to know for I'm basically like there are 4 or 5 things we wrote, and I already sent you the list that we want to have. If we can have undergraduate level scientific exchange, or we can have postgraduate level scientific exchange. So it's good. It's good. Even online lectures, if we can arrange between each other. So that is a good way to exchange knowledge in between the 2 universities and in between the 2 colleges. So I'm sure we will gain a lot from our side, from your expertise and from your system and from your infrastructure. And the other thing is one thing also I want to, because many students are here, so I would like to tell the students that to get an entry in PhD in Japan, you don't need to have a master's degree. Okay, it's not same as in India. You can have your bachelor's degree, But in our country, the bachelor's is 5 years course. It's unlike the other countries where bachelor is 6 years course, right? So in Tokushima, you need to have 6 years of education after doing your senior secondary to enter the PhD program. So, so what many students do is they go to Tokushima after their graduation, completing their undergraduate course. They join a research program for 1 year to complete that 6 years of education, and then they can carry on with the PhD. Am I right, Matsuka Sensei?
Yeah, no, from your university after graduation, 5 years course graduation, they can enter the PhD course directly.
No, but the number of years after your, I think there is a minimum criteria of 18 years to enter PhD program. Is it right? 18 years of education before
I need
entering.
to check the rule again, but
not
yeah,
17.
Not 5 years, okay, I think.
But they have to have an additional course for 1 year, or if they have done something else, it's also okay.
But you remember the UFE, or let's say UFE in China, they also have the 5-year program, and she entered the PhD course directly.
Oh, immediately after completing her undergrad? Okay. Okay. So,
but I need to check.
Okay. Okay, and other thing is that, as Tiwari sir said to me, that if some of your students come here or some faculty member come here, so we have a very good guest house with very good dining hall. So their stay will be from our side. So I think it's very, it's available. It's not so difficult to get. Am I right, Tiwari sir?
Yes, that too with the permission of our administrative authorities, like Vice Chancellor.
Of course, we will need permission.
We will get the guest house, no problem. We can host for the guest house. Yeah. So the rest of the thing will be managed by the person coming from Japan.
Okay. So I think that's okay. If anybody wants to say something.
Can I share something?
Yes, sir. Yes, sir. Please, Varsi, sir. He's Dr. Varsi. He's Professor Varsi. He's our local coordinator for Global Initiative of Academic Networks. Actually, he is the one who helped us to get the course, GIAN course. He coordinated this GIAN course. So please, Varsi, sir, please.
So let me welcome Professor Otto Baba, Professor Yoshi Jo, Professor Bhargava sir, Professor Tiwari sir, the principal of Dental College, Dr. Professor Saishta. I must congratulate you for organizing the first GIAN course after this pandemic. So credit goes to you for this organization. There are a few things. This GIAN, like Global Initiative of Academic Networks program, is a flagship program of the Government of India through Ministry of Education, and runs through IIT Kharagpur. So this is a very prestigious program, and the idea is to get the best of the minds to our campus. Basically, this program is offline program, but due to COVID pandemic, we are hosting and we are organizing this online programs. There, as far as the collaboration is concerned, collaboration, as you were discussing, can be at various levels. So one level that we are doing is the exchange program of our expert can give talks online, or their expert can give talks online, and that has to be documented. If you are going to have an MOU, it must be clear, like 1, 2, 3 points. The first one is lecture series. The second one is like internship. What other institutions do, like they send their students for the internship, and the cost of their stay living are borne by the institution, collaborating institutions of the country. And the same thing, the people, when they come, as Professor Tiwari sir was saying, that we can provide guest house and accommodation here, like for their internship if they are coming to. So this is the second level of collaboration. Then there is short-term course. Like for example, if we want some expert to come here for a semester to teach a course, we will certainly provide their stay here, provide their accommodation for that. In the same way, when they would like to have expert from us, we can go there. They have to bear all the expenses or some kind of things that we can manage way out, and you can talk the financial aspect at a later stage when the things is in the progress. And then there is like funding for the projects, like some collaborating projects we are doing. Who is funding? The university there in Japan is funding agency. We can have a principal investigator or co-investigator or co-PI, something like that. Some kind of collaboration would be like ours. Or if we are having a project, we can have the manager expert as co-PI or something like that. These kind of collaboration is a mandate for this global initiative of GIAN project. And in terms of like next step, it not be in a part of the MOU, but generally, as we were talking about the scholarships are for general students. Our student can apply, a student from Calcutta can apply, a student from Chennai can apply. But for the in the AMU, if we are getting preference that our students, certain number of students will get admitted only from Dr. Zakir Hussain Dental College or something, Ziauddin Dental, sorry, our dental college, that would be much beneficial to us instead of like individually applying and getting more competitive than we have an understanding of MOU that certain number like 2, 3, 4, 5 number of students because of the MOU we can have from Dental College, Aligarh Muslim University. And in the same way, if they want to come here, we can have some kind of internship, provide the expertise, they can come and we can give preference to the student from the university in Japan. So these kind of collaborations that could be documented, could be mentioned in the MOU, and then we can proceed. So it can be a start from lecture exchange program or from funding to the project. So these all are part of the MOU. So I'm sure like the people, the senior academicians and professionals and doctors like our Dean, Professor Rakesh Bhargava sir is there, Principal Professor Tiwari sir is there, Dr. Shaista Afroz herself is a well-known doctor. So you can all have together, and to execute this process, I will be being the local coordinator of the Global Initiative of Academic Networks. I will be happy to initiate or help anywhere you need that. So with these few words, I would like to thank you for being here. I know we must, and we appreciate you for taking time to share your thoughts with us. Even we are facing the corona, and we are slowly moving out of the corona. Hopefully, we'll get soon over from this pandemic. So thank you very much for joining us. Thank you for to everyone for this concluding session of the GIAN project organized, the first one after the pandemic, organized by Professor Shaista Afroz. Thank you very much.
Thank you, sir. Thank you for enlightening us. Yeah, whatever he said is valid. So Matsuka Sensei and Baba Sensei, thank you for joining us for this discussion, and I hope we can take it to the next level now. And please, as Vashi sir said, that what is the, like, there are hierarchies in deciding what plan of action we can decide, that what we want later on from this, what are your expectations and what are our expectations from this collaboration. So my expectations are simple, that our students should get broad exposure and good education. What they are getting here, they should be able to get beyond it, and I hope that will be fulfilled by this kind of collaboration. Thank you, sir, and thank you, Tiwari sir, and thank you, Bhargav sir, for joining us for this small meeting. And this was first meeting. Baba Sensei, do you want to say something?
Thank you.
Okay, thank you very much, Shaista. And yeah, I think as you mentioned, so the finding program is very important, I know. And actually, so we will start at the point by doing something with a small funding. with small funding.
Okay.
So, and little by little, so we are thinking about how to get the fundings from the government, even from the universities, or even from the other ways. So I know, so we can do everything so we want, but everything we want, so we can start little by little.
Yeah, I can understand, sir. Little by little is always better.
Dr. Shasta?
Yes, sir.
Yeah, again, I want to thank all, especially Dr. Otto and Professor Matsuda for such a word for the nice collaboration. And we hope that in future we will get some collaboration from not only in the dental college, but also in the medical college. We will try to get everything. Yeah, because everybody needs that. They should have something better. We also need that.
Yeah, yes, sir. I understand. We need to. Actually, globalization is the need of the hour.
Yeah,
The only thing we don't want to globalize is coronavirus. We want it to
We
be.
have contained it only. Japan is also going to contain it very soon.
Yeah, of course. I am so. I think we will control it, and I think corona itself will get tired of infecting human beings one day. I hope so. So thank you, Varsi sir, for giving your words and for your guidance. And Tiwari sir, do you want to say something so that we can?
In the last, I want to say that it is a very good initiative and hope for the best.
Thank you, sir. Thank you, sir. And Matsuka Sensei, do you want to say something finally before winding up?
Thank you for having the good opportunity to have this discussion. And we want to have the collaboration, and we can start writing the MOU at first.
Oh, that's a good news. Thank you, sir. Thank you very much. That's the way to go on. So I think with this, can we just can we move on to our next program, that is felicitation of our guest? Is it all right now? Is it okay with everybody? Tiwari sir, Bhargav sir, Baba Sensei, Varshi Sensei, it's okay?
Yeah. Sure.
Okay, so next is over to Zeba Nas. She's our moderator today. So we next is felicitation of our guest. And okay, Zeba, please go on.
Now we are coming to the end of this event. As we all know, the end of the story is the new beginning for many others. And on this note, let's start a remarkable, memorable, and a knowledgeable valedictory session. On behalf of organizing committee, I sincerely thank the dignitaries for being with us and enlightening us with their enthusiastic remarks. On behalf of organizing committee, I request Dr. Rakesh Bhargav sir to present the certificate to our eminent speakers and event coordinators. I request you, sir, to give certificate of appreciation to Professor Matsuka sir for his wonderful lectures he presented to us.
Yeah. Thank you, Dr. Matsuka, for your kind lecture. And I know that most of the people have really appreciated that. And it's my pleasure to present you this online your certificate of appreciation. Thank you, Professor Matsuka.
Thank you very much. Thank you.
Now it's time to present certificate of appreciation to other speakers. I think they are not in the meeting, but we will appreciate them. First one is the Dr. Mehdi Hayat sir for enlightening lecture, Dr. Sharik Naeem sir for his engaging lecture, and I request Dr. Aftab Ahmed sir for to take this certificate of appreciation. And then Dr. Dalia Rafat ma'am for her knowledgeable session. Now I request local coordinator Professor M.J. Varsi sir to accept the certificate of appreciation for his valuable support. Thank you, sir.
Thank you so much.
Now it's time to felicitate the one without whom this event would not be possible. I request to present certificate to Dr. Geeta Rajput ma'am and Dr. Sajjad Abdul Rahman sir for speaker as well as event coordinator.
Thank you, Dr. Zeba. Thank you to the entire team.
Thank you, ma'am.
Thank you, Zeba.
Thank you, sir. Last but not the least, I would like to call Chief Coordinator Dr. Shaista Afroz ma'am to accept the certificate.
Thank you. Signed by myself. Thank you very much. Thank you.
A big thanks to everyone, whoever put their valuable time to make this event successful. And I thank all the participants for their active participation and to make this event successful. As we are coming close to end our valedictory ceremony, I invite Professor Shaista ma'am to propose the vote of thanks to the audience. Over to you, ma'am.
Thank you very much. I thought people are tired of listening to me all the time. But anyway, I would like to extend my sincere thanks to Professor Matsuka, Yoshizo Matsuka. He is still my guide. He taught me a lot when I was in Tokushima, and still for little things and big things also, I consult him if I have some doubt or something related to research. And sir, I can understand it must be very tiring for you to deliver 10 hours lecture in 5 days, but we enjoyed having you here and we learned a lot from you. And I hope we can have more number of sessions in different form. It is not necessary to be the GIAN platform. It can be a lot of platforms. One platform lead way to another one. And I'm also thankful to Professor Uddubaba Sensei for joining us today and giving his valuable time and giving his comments and showing his giving a very assertive attitude, showing his showing his approval for a collaboration between with us. So I'm really thankful to you, sir, for your positive response. And then I'm thankful to Professor Rakesh Bhargav, sir. I know, sir, you are very busy, but still you always take out time when it comes to dental college. And you, even though you have to run from OPD, but still you manage to be with us for little thing and for big events and for small events always. Thank you very much, sir. Keep supporting us. And I would like to thank Professor R.K. Tiwari, sir, also for listening to me throughout about this GIAN. I kept on telling, sir, we have GIAN, and you have to be there and you have to listen to us. And he was always very positive, and he gave his thorough support to us, to the Department of Prosthodontics, of course. And then Professor M.J. Varsi, sir, thank you very much. I always call you anytime when I want to. I never look at the watch. I never look at the clock that it's right time to call or not. And even I threw a lot of messages to you to clarify my doubts about this program. And I know without your support, it was difficult for me to apply even from the beginning until this day you are here with us. Thank you very much, sir, for being with us and for your guidance. And finally, I would this whole event was impossible without our organizing team, Department of Prosthodontics, all the teachers, Professor Gaurav, Professor Abhinav, Professor Geeta Rajput, Dr. Shatarati, Dr. Sajjad, Dr. Pankaj Kharare, and Dr. Amna, and our team of residents. They work all the 5 days. They were here, sir, listening to you and trying to understand everything, which was, of course, this was a new, like this orofacial pain has never been taught like this before. So this was altogether a new experience for all of us. So I am really thankful to all our residents. They worked tirelessly to make it, everything practically possible. So they were, you saw them one by one during the question answer session and during the moderation. Dr. Sapya, Dr. Zeba, Dr. Priyanka, Dr. Shivani, Dr. Tuba, Dr. Shua, and Dr. Dhanush. Did I leave any? Dr. Abhirami also. So they were all here every single day. You didn't see them, but they were there all the time listening to you and framing questions to ask you. and taking my approval, ma'am, this question will be good to ask. But anyway, I was not expecting that they will be able to perform so well, even behind the curtains. So thank you very much to all the team members. And thank you all of you once again. And with this, we have come to our end, and over to Zeba. She will tell you next.
One more announcement. There was a quiz competition for 2 days. For the winners for the day 1 are Dr. Sarwar Hashmi sir and Dr. Anand sir. Dr. Sarwar Hashmi sir is in Department of Oral and Maxillofacial Surgery from Dr. ZADC Dental College, and Dr. Anand is from A.B. Shetty Memorial of Dental Sciences from the Department of Oral Medicine and Radiology. And winners for day 2 are Adila Majid and Dr. Marimuthu. Many congratulations to both of them. Now, as we are going to end this program, we will end it with AMU Tarana and National Anthem. I request all of you to stand up while the Tarana and National Anthem is being played.
No, actually, just a second. Sir, to Matsuka Sensei and to Otobaba Sensei, I would like to tell that it is tradition that when we end a ceremony, we always play our university Tirana. And after that, we play national anthem. So when national anthem is played last, so when we play national anthem, we have to stand up as a mark of honor. And in the meanwhile, we can keep our cameras switched off if we want to. Thank you very much, everybody.
Tarana is university song.
Yes, Tirana is university. Tirana is university anthem, you can say. Thank you very much, sir.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
Thank you, sir. With this, we are ending today's meeting. Thank you for being with us today. Goodbye. I hope to see you all soon and hope to meet again on some other platform. Thank you very much for joining us. Thank you very much. Okay, we can end the meeting. Thank you.